Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning and welcome everyone to this seminar. On behalf of the One Day International Webinar on Oral Health Therapies Committee, the Dental Health Department Poltekkes Kemenkes Semarang, I would like to extend a warm welcome to all of you for taking the time to attend this event. It gives me great pleasure to be the anchor for this seminar, and I am excited to be hosting. I would like to take a moment to express our immense gratitude to the PT GMI, Persatuan Terapis Gigi dan Mulut Indonesia Daerah Jawa Tengah, who have made this seminar possible. Without their support, we would not be here today. We are truly thankful for their efforts and contributions toward this event. Today's seminar is all about preventing and controlling infection post-pandemic COVID-19 for dental auxiliaries, and its significance is today's work. We have some distinguished speakers lined up who will be sharing their insights and knowledge Thank you, everyone. Please take your seats. Ladies and gentlemen, so that our activities today run well and smoothly, let's pray together, which will be led by Mr. Nanang Kosim, Sarjana Pendidikan Islam, Magister Pendidikan. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, please allow me to lead according prayer religion Islamic for Mr. and Mrs. who have others religions and belief are welcome to pray in your own beliefs. Ala hadiniyah wa ala kulli niyatin sholihah li hajati fi majlisina hada khossah Ridha illah wa li syafaati Rasulillahi sallallahu alaihi wasallam. Allahumma anfa'na bima 'allamtana wa 'allimna ma yanfa'una. Rabbana hab lana min azwajina wa dhurriyyatina qurrata a'yun waj'alna lil muttaqina imama. Rabbana dhalamna anfusana wa illam taghfir lana wa tarhamna lanakunanna minal khasirin. Allahumma barik lana fi majlisina wa barik lana fi ilmina wa barik lana fi umurina wa barik lana fi auladina wa barik lana fi ustadina ya Allah. Allahumma rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala sayyidina Muhammad wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa barak wa sallam. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Coming up to the next agenda, please join us in welcoming the head of the Dental Health Department, Poltekkes Kemenkes Semarang, to give us the welcome speech. Profesor Dr. Gigi Diah Fatmasari, MDSC, the time is yours.
Thank you, Bu Hermin. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Director Health Polytechnic of Semarang, Mr. Jeffrey Ardianto, Master of Applied Science, who is joined from Denpasar. Good morning, Pak Jeffrey. Are you in Zoom already, Pak Jeffrey? I think already. The Honorable, the Vice Director.
Yes, good morning.
Yes, morning,
Morning,
Pak
bro.
Jeffrey. Thank you very much.
How is it going?
Yes,
Is it
good.
fine?
Everything's okay, Pak Director.
Thank you, thank you.
Yes, thank you, Pak
Okay,
Director.
let's continue.
Yes. The Honorable, the Vice Director 1, Health Polytechnic of Semarang, Bapak Dr. Bejo Santoso, SSTMKes, Head of Indonesian Association of Dental and Oral Therapists Central Java, Bapak Dharma Wahyu Edi SKMMM. Thank you, Pak Didi, for always accompany us and also give credit point for dental therapists who join with these participants with 3 SKP ya Pak ya. Okay, thank you. The speakers, I think already joined also 5 speakers from 4 countries, Malaysia, Dr. Nikla Survia Andiesta. Selamat pagi, Dokter. I think Dr. Nikla already joined also in this Zoom. From Australia, Dr. Solahuddin. From Australia, Prof. Aris Nares. Good morning, Prof. Aris Nares. From Brunei Darussalam, Dr. Solahuddin Jawahari Arif Ihwan. From University Brunei Darussalam. And from Indonesia, Dr. Gigi Raden Roro Pipit Okti Kusumas TV from Hospital Muhammadiyah University Yogyakarta. And Dr. Gigi Lani Sunarjo, Master of Dental Science from Poltekkes Kemenkes Semarang, who joined luring in this room. Morning, Bu Dr. Lani. Honorable all heads of department at Nehal Poltekkes of Polytechnic of Semarang. I think already joined also Bu Dr. Kristiana, Bu Siti Masroha, Bu Fatimah, and others. Thank you for already joined in this Zoom meeting. The head of the study program and secretary of dental head department, who also joined luring in this room. And all distinguished committee from PTGMI and from JKG and all my lovely webinar participants. First of all, let us thanks to Allah Subhanahu wa Ta'ala who give us health and prosperity to join in this event. I'm really happy to be here to welcome all the participants of one-day international webinar of dental health, health collaboration of Dental Health Department, Health Polytechnic of Semarang, and Indonesia Association of Dental and Oral Therapists Central Java. Ladies and gentlemen, Poltekkes Kemenkes Semarang, or in English Health Polytechnic of Semarang, is the largest and robust health polytechnic in Indonesia. We educate students from Diploma 3 to Applied Masters. Our department, known as Dental Health Department, consists of 3-year diploma and 4-year diploma or bachelor program. The one-day international webinar take theme Preventing and Controlling Cross-Infection Post-Pandemic COVID-19 for Dental Auxiliaries. This interesting topic still very important and needed by all dental team who works at hospital, community services, university, and other sectors with any possibility to get cross-infection. The international webinar is attended by around 700 participants consisting of students of Faculty of Dentistry, students of dental health from Poltekkes, lecturers, clinical instructors, dental therapists, and other participants from Indonesia, from Taiwan, and from Malaysia. I'm really appreciate for your kind participation, and hopefully it can improve the networking among the participants. Finally, in this good occasion, allow me to convey my greatest appreciation to the Director of Poltekkes Kemenkes Semarang for the fully support Indonesia Association of Dental and Oral Therapists PTGMI Jawa Tengah, all speakers and all committee. On behalf of the committee, I apologize for the mistakes that may be occur either intentionally or unintentionally. Give me time to say some poem or pantun, but in English. Not yet, yeah. Sunset is setting above the crashing wave. Make me remember the past memories. Giving attention, trying to beat the haze. That's how I can understand what the speaker says. Hopefully everybody can understand what the speaker says. As the event concludes with grace, warm memories in our embrace. A fond farewell, our path to trace. Till next time in the same sweet space. Hopefully we can meet again in the next sweet space. Enjoy the webinar, absorb the knowledge you will get from the great speakers. Sekarang di bahasa Indonesia. Burung cenderawasih dari Irian. Terima kasih dan cukup sekian. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Distinguished guests, we are going to listen to the opening speech from the Director of Poltekkes Kemenkes Semarang, will also officially open this one-day international webinar. Please welcome Mr. Jeffrey Ardianto, Master of Applied Science.
Thank you, Ms. Hermin, as the MCs for the webinar this morning. I would like to start my speech. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Respectable all speakers, Dr. Salahuddin Jawari Arif Ifwan from Dentistry Program, PA PRSP Institute of Health Science, University Brunei Darussalam, Dr. Nikia Sulfia Andista, School of Dentistry, International Medical University Malaysia, Prof. Aris Nares, Gilmore District Health, Australia, Dr. Dentist, Raden Roro Pipit Okti Kusumastuti, MPS from University Muhammadiyah Yogyakarta, and also the last speaker, Dr. Dentist Lani Sonarjo, MDSC from Head of Postgraduate Program, Polytechnic of Health Semarang, the Honorable Oral Health Therapies and Professional Organization, the respectable management, lecturers, faculty members from Dental Health Department, Health Polytechnic of Semarang, and also Health Polytechnic of Semarang Management from others department. I'm proud of the alumni and the student of the Dental Health Department, Health Polytechnic of Semarang, and also Health Polytechnic throughout Indonesia. Ladies and gentlemen, allow me this opportunity to welcome all these conference participants by first praying our gratitude and praise to the Almighty God for all His blessing, grace, and mercies that have made us possible to gather here in this room in excellent condition and health. Dear keynote speakers, distinguished guests, and participants of the one-day international webinar on oral health therapies with the topic Preventing and Controlling Infection Post-Pandemic COVID-19 for Dental Auxiliaries. The Dental Health Department of Health Polytechnic of Semarang is very pleased to host this one-day seminar in Semarang. Welcome to West Campus and also welcome to Semarang City. Improving health service is useful for achieving the ultimate goal of health development, namely optimal health, including dental and oral health. The existence of health facilities, as well as doctors and dental therapies, is essential in the health service provided to the community. Dental therapies as health workers not only play a role in managing and caring for people's teeth and mouth, but also in preventing disease. The dental work environment is a source of infection transmission. Therefore, infection prevention and control are needed in every treatment in the field of dentistry. Cross-infection is the transfer of microorganisms that can occur in dental health care setting in several ways, including from patients to dental health care workers, dental health service personnel to patient, patient to patient, and places for dental health service to communities, including the families of dental health service workers. There is a very high risk for dental healthcare workers to get cross-infection when carrying out dental procedures because they can come into direct contact with blood, saliva, and contaminated fluids. Lack of attention to infection prevention and control measures in dental health service facilities can have an impact on dental health workers who provide service as well as patients and the visiting public. This one-day seminar activity aims to get how effort to prevent and control cross-infection in dental health service procedure in clinics in several countries to increase knowledge and expand insight so that we can better effort to prevent and control cross-infection in dental health service procedures in Indonesia. Hopefully, we all can significantly give more contribution to the nation's advancement in the not too distant future. To all of our distinguished guests and participants, thank you for being here. Welcome and enjoy the seminar. At the end of my remark, allow me also to convey several poems, like Prof. Dia. A bird on the tree is a pigeon.
Cakep.
Luckily, it is already free.
Great.
A student should be diligent and full of spirit to be great.
Terima kasih Pak.
Once more, an old man wears converse. He walks fast with curiousness. Follow me, follow the parents' orders. Their prey is your
Thank you
successfulness.
Pak Dir.
With Basmalah, Bismillahirrahmanirrahim. Officially, I open the International One-Day Webinar on Oral Health Therapy.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you Pak Jeffrey. Have a nice day Pak.
You're welcome.
Okay.
Thank you. You're welcome.
Thank you for your time, Mr. Jeffrey Ardianto. We hope you can follow this agenda until the end. But if you have another agenda, please feel free to continue. Thank you very much.
You're welcome, Ms. Hermin.
Okay, ladies and gentlemen. We have just followed the opening ceremony of the one-day International Webinar on Oral Health Therapies by Poltekkes Kemenkes Semarang. It's time for us to come to the main agenda, the presentation session that will be delivered by our special guest. It is indeed a great pleasure for us to welcome Dr. Solahuddin Jauhari Arif Ihwan, Professor Aris Nares, and Dr. Nikla Survia Anyesta was the speakers for this first session. The session will be guided by Mr. Salikun, Sarjana Pendidikan, Magister Kesehatan, as the moderator.
Morning Dr. Solahuddin. Dr.
Good morning.
Solahuddin.
Assalamualaikum, good morning.
Waalaikumsalam. Dr.
Ya.
Nikla. Pagi Dr. Nikla.
Selamat pagi.
Pagi, good morning Doctor. It's nice to meet you Doc. At Zoom. Next year luring ya Doc.
Iya
Thank
dong.
you. Yes.
Oke, Pak Mr. Salikun, Sarjana Pendidikan Magister Kesehatan, is the lecturer at Dental Health Department Poltekkes Kemenkes Semarang. He was born at Bumireja, April 4, 1962. And this address in Villa Mula Warman, Kavling 50, Kelurahan Jabungan, Kecamatan Banyumanik, Kota Semarang. So, no furthermore, the time is yours, Mr. Salikun.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah. This morning we have meeting in this session. There, the sir and madam, all the participants, good morning. Thank you very much for coming to our international webinar. The Honorable Director of Health Polytechnic Semarang, the Honorable Chairman of Dental Heads, Prof. Dia, and all of the dental health department lecturers, and also honorable all participants of this international webinar. Good morning. Ladies and gentlemen, I'm Salikun. As the moderator in this session, I'm very pleased to see you here and welcome all of you. Ladies and gentlemen, let me introduce to our outstanding speaker today. The first have Dr. Salahuddin Johari Arif Ikhwan. And we also have Prof. Aris Nares and also Dr. Nicola Serve Adista. Let me inform you how the presentation will be going on. The first, all the speakers will be invited one by one to present the material. Each speaker will be given 30 minutes for the presentation. After that, all the presentation are finished. Then there will be a question and answer. The participant can write, to be effective, the participant can write the question in the chat box during the presentation. Now, allow me to welcome the first speakers, Dr. Salahuddin Johari Arif Ikhwan. Good morning, Doctor.
Assalamualaikum. Good morning, Mr. Salihud.
Mashallah. Waalaikumsalam. Good morning.
Yeah. Can you get me now?
Yeah. Now, please welcome to Dr. Salahuddin to deliver the presentation about the guarding against cross-infection with the practice in the dental operating theater. This floor of you.
Okay.
Okay.
Okay, thank you very much. Okay, Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. First of all, I'd like to thank the organizing committee from the Poltekkes Semarang for kindly inviting me for this to become one of speaker for this international conference. Also to thank to all of the organizing committee, honorable guests. So inshallah, I got so many slides, but not so many of them that I will highlight. There's some of them because some of the topic will be explained by different next speakers. This the topic is given to me to be presented.
Okay.
Yeah, actually nothing new here. Yeah, so it is about how to protect ourselves and the patients and from the cross infections where in the dental operating theater. This is the outline of my presentation today. This is the introductions for this first part, introductions. First, we go with this very general term about the definitions about what is cross infections. thing that you can see on the slides. The definition of cross-infection is the transmission of the pathogenic microbes or infectious agents between the patient and staff where within a clinical environment. In that the term we understand now is not there's any place but in the clinical environment, because our focus with our working place now, we are working in health facilities. It means the object will be two, the patient and the staff. So this I give example, being as the dental health care person, the dentist, nurse, patient inside this simple example in a dental clinic. So we are in dental clinic or even OT, operating theater of our dentistry. See these four things that we have to consider first. It has been mentioned previously by the by Mr. Jeffrey. And then careful is about something like from bloodborne, from the blood, because we are dealing with the blood. Next one, saliva, it is a mirror of the blood, especially that's those carried by the air bioaerosol. Next, water droplet. We are usually in our environment, we use AGP, aerosol generating procedure, and then direct contact. So maybe for other discipline like medicine, they deal with blood and direct, but we are dealing with this T, with this two, saliva and water droplet, because our nature of our work, using like hand paste, for instance, or the ultrasonic scalar. This about blood, one thing we know is we are very prone and the greatest risk of this. This now the bilamenzelic, we don't, because we are dealing with sharp instrument. The thing we cannot do, never do this, returning the recapping the needle, using our hands. And this during COVID-19 very popular. Actually the COVID-19, despite this lot of problem, it remind us to become much more careful, much more alert to any infection because of airborne, because of the aerosol. All of cross infection that can happen in dental setting. And this you can see. By the way, I will share the slide. This and slide, you can simply just click the link or just go give the textbook or the paper. From where this I got the source of the reference for this presentation. So mostly we are dealing with a lot of viruses and then bacteria. So for instance, like viruses, none of them they are normal flora. We know that hepatitis B and C. This in front of textbooks, no COVID-19 yet. But especially you have to be careful because it's commonly because COVID-19 finished, we have vaccination, but we have another virus, but we don't have any vaccine. For instance, HIV, and some other viruses. And then bacteria. You see here, most of the bacteria, they are quite unique. STD, sexual transmitted disease. And then not yet the arch enemy, long-lasting enemy, MTB, tuberculosis. And then this one normal flora, Streptococcus pyogenes. This is the way of the transmitted inoculation, inhalations. This I cannot read because there's so many. There's another paper they highlighted here. This I put it from this textbook and the paper. Now this we have to highlight who is the most susceptible to cross infection in dental setting. There are two actually, not only one, not is but are. First, ourselves, dental healthcare personnel, it is dentist, dental nurse, dental assistant, dental auxiliaries. Next, our patients. But to be honest, yes, we are. We are the member of this, because why? Every day we look at so many patients. We may see 100 patients. Say in 1 month, how many patients? 1,000 patients, maybe more than that. We don't know the patient healthy or not. We just look at here that the cross-infection chain. So say this the reservoir from the patient. We don't know the patient got what kind of disease the infectious disease of the patient have. Can be transmitted to us using different way. we are as the person also, dentist also, nurse also, we have capability to infect also the patients. So we must keep ourselves healthy as well. So we are surrounded by a lot of microbes in our working place. Okay, so since this lectures meant for dental auxiliaries, especially dental nurse, so this is to highlight the importance of unsung hero. Yeah, the dental nurse. Yeah, usually just patient only. Oh, that doctor's very good. That dentist very good. But sometimes they forgot about the importance of dentist. I have to be frankly speaking. Yeah? No nurse, dental nurse, understand we cannot work. Now the era of four-handed dentistry, I cannot work alone. Yeah, this against the SOP of infection control. We need someone else. Yeah, we need someone else to help us, which is trained person. Who are they? Dental auxiliaries, dental nurse, dental assistants. So they are very essential. Simply to say, no dental nurse, no dental assistant, no working. Sorry, I cannot open the clinic because nobody helped me. Yeah. So this is to highlight here. It's according to the United States. This very popular slide actually. Yeah. That's unfortunately, yeah, dentistry quite littering job, yeah, creating money, yeah, number one. But unfortunately, also number one in, yeah, considered as the most unhealthy profession. Yeah, is dentist and the assistant. And you see also here in surgery, medical assistant. That's the surgeon. That's number just quite far from us. Very interesting, right? We create money a lot, but see, we have risk also a lot. Okay, that's all for us. But now about the patients, yes, the patients, our customer, they come to us, they want to get help. They need help. They want help. So they come to us wherever in hospital, dental clinic. But how many times they are exposed? Okay, dentist, it is impossible to, they come at once. They might come twice, 3 times, okay, by appointment. So imagine our customer, they come to us healthy just to have, they have to decay, yeah, want to have their tooth to be filled, to have restoration, but return back, oh, they get nosocomial infections. Yes. And now this, we used to call it nosocomial infection, but actually the name now is HAI, healthcare associated infections. Okay. They got this pathogen, these microbes from clinic, from health facilities, whatever, hospital, dental clinic, anything. Yeah, in Indonesia we call it puskesmas also. Yeah, from where the bacteria, from where the virus, especially bacteria, yes, from other patient. Yeah. Especially we are worried about the, okay, I'll explain later on. Especially this, I'm given topic for about the operating theater. This, the patient come to us for having surgery. And then somehow something happened, yeah, maybe not only to extraction, maybe they need to do some maxillofacial gel reconstructions, for instance. So there's infection. They got infection at the surgical site. This is the most common, not only dentistry, but other. Yeah, the number one enemy of surgery is the SSI, surgical site infections. This is not by the virus, but bacteria. What kind of bacteria? Common bacteria, which is the bacteria that's actually normal flora. But as a matter of fact, this, the WHO has put this on highlight. This, the link can be clicked. So this claim million people, especially in the country where they cannot provide good standard for cross-infection, for infection control. Okay, so this, yeah, back to the nosocomial infection or HAI here. Because they, from where, yeah, the patient got the this HAI pathogens, yes, from the environment in a clinic, health or healthcare setting, hospital. And we know that the operating theater, they are in hospital, of course. Yeah. So they can be part of normal for patients. They can be part of the medical device and instruments. They can be transferred from the instrument hospital to other patient and vice versa, like a cycling. Okay. talking about the pathogen here, especially bacteria, because SSI caused by the bacteria, yes, they are very common pathogen actually. They are against this normal flora. You have, I have, but this can be deadly. SA, Staphylococcus aureus, and then EA here, Pseudomonas aeruginosa, and then E. coli, this epidermidis staphylococci, and then E. facialis. Okay, but they are, we can say normal type. Maybe don't worry, we can treat antibiotic, but what happened? This, we are worried, sorry, we are worried about this, including this. This now, the microbiologists in the hospital, we are worried about these three things, yeah. The antibiotic resistant microbes of pathogen. Normal, so they are normal bacteria, Staphylococcus aureus, but they have become resistant to the strongest antibiotic, and enterococci, and also this one, Enterobacteriaceae. So as you can see, the left, there's caricature here, or there's like a grandma, something like elderly, worry about, oh, there's the monkey virus, monkeypox virus, or after COVID-19. Doctor say, don't worry, not the pox virus kill you, you'll be killed by the MRSA first. Staphylococcus aureus, which is resistant. No antibiotic can kill this. Okay, and let me brief the history of this SSI here. Actually, SSI is something like become a history a long time ago. People before they got amputations because the war at the past, amputation, not the the surgeon successfully did amputations, but the patient died not because of bleeding, but because of the SSI infection. At the time, no antibiotic. They don't know what is infection control. They have a limited knowledge about that. Yeah. Until in the modern way, this Dr. Joseph Lister introduced, okay, so we need to clean the hospital, the operating theater or surgical site using antiseptic at the time. Yeah, he used phenol, carbolic acid. Yeah, in Indonesia we use Lysol, something like that. The smell, I think you're familiar in hospital, yeah. So he used like this, like spray to clean everything. But maybe just to invite all participants, look at this. Oh, this according to textbook, they are the first who perform aseptic surgery at the time. But according to our standard, not at all. Okay, they spray everything, the location, using the dressing, using the carbolic acid, antiseptic. But look at them, they're still wearing the street clothing, still wearing shoes from outside. So that's why, well, what's happening then? If we have time machine, go back to that time, this last centuries, oh, you'll be laughing. What is this? What are you doing? Doing surgery, but not the aseptic condition. For them, this is quite aseptic enough. Nowadays, we are doing this like such kind of room. Okay, by the way, just about term, yeah, glossary not to get used, yeah, because here mostly in the British system we call it either OR or OT, yeah, operating theater or OR, whereas in Indonesia usually we use OKA, right? OKA, operating kamar, from the Dutch kamar bedah, operasi. Yes, I got confused when I was first time moved outside, yeah, first time I went to Malaysia. OT, and we all OKA, OT, okay, finally just learn about the language. Yes, operating theater. But why theater? Because of this history. At that time, doing surgery is something like a kind of show. So people can join, especially the future doctor, they attended this. Look at this, the end of 19th centuries, people, the doctor and the nurse doing surgery, and so-called aseptic technique, but being watched by many participants here. The future dentist. Sometimes only ordinary people, they pay. Okay, I want to attend. How you are doing surgery? Okay, don't worry, doctor, this last century still happen. 20th century, the Second World War, this in America. Okay, they are wearing masks now, better. But look at them, the nurse. Oh, what happened with the air circulation there? Yeah, none of them wearing masks. Okay, see, you see what can we see from here? We can see from here. There will be like progressions, updating of the standard of infection control. Okay, Next, let's go to infection control, main topic here. Okay, maybe I will just skip many of them because will be explained by the next speakers. To what infection control, the meaning is to prevent, to cut, to prevent cross-infection, by cutting the possible routes of transmissions. So this, our focus, not only patient and healthcare workers like us, but also the staff and also the visitors. But for the operating theater, usually we are focusing these two, okay? Because as you know, we don't know the patient, they are healthy or not. Are they, maybe we check, okay, COVID-19 free, no problem, swab, but maybe they have another viruses. Who knows? Maybe the patient have tuberculosis bacteria which is resistant to the anti-tuberculosis drug, whatever. So we need to be careful. In other words, we can say like a bit extreme, we can call it. We have to consider all patients, they are harboring pathogen. We have to be paranoid of this. It doesn't matter the patient, our colleagues, our friends, our family, consider them as pathogens carriers. Okay, that's this. Therefore, we have to make sure we have same standard. We call it standard precautions. Okay, it means all standard, all of the procedures for dealing with this patient, for any kind of patient, must be conducted using this standard. Yeah. Okay. So this has been already established, but there are two layers of the infection control here. First, I mentioned just now, but standard precaution, another name, full name actually, standard infection control precautions. But it's too long, usually we can call it standard precaution. This to be used on all patient, all time. Yeah. It doesn't matter. So this to prevent transmission of from ourselves, and the patient from these four things: blood fluids, contact skin, mucous membrane. We're dealing with that. Next, this one, we know the patient got this already. Oh, we are going to do surgery patient which we having, like say HIV patient or tuberculosis patient, but we have to do surgery. We have to do treatment. What we have to do? We have to have another step, another precaution. What we call it transmission-based precautions, because this we know the patient got disease. Because we rely on the first one, be not enough. So they are related here. Okay. This, I really updated before from the WHO, but this specific because I'm using now. The place I'm teaching now in Brunei. I think similar like Malaysia, we use on British base, we follow the protocol from United Kingdom and from UK, from NHS here. This the 10 steps we have to follow. We have to monitor for standard precautions, starting from we have to assess the patients, the patient healthy or not, screening, and then second, hand hygiene, and then respiratory hygiene, PPE, and then management of care environment, care equipment, instrument, healthcare linen, and blood fluid, and then the waste, how we do the face, and then also the occupational safety, especially for prevention of exposure. Usually we are dealing with sharp instrument, so we have to be careful. That is the example of standard precaution here. This example. Usually this poster we can find everywhere. This in the healthcare setting. During COVID-19, usually this very popular. Droplet isolation, airborne isolations. Many combination of them. This is what we have to do. COVID-19, we have follow this. Airborne contact droplet isolations. How about the next one? Transmission-based precautions. You know the patient got the disease here. There's another additional setting. Actually, none of from this they are new. They are quite old, has been known even before COVID-19. But if we realize this, oh, my God, this one actually if we follow this since the beginning, no need to worry, no need to create new protocol. As a matter of fact, yes, during COVID-19, if we follow this protocol, should be no problem, but we only need to provide more material for instance, like this. Oh, we need the FRSM, fluid resistant surgical mask, or RPE here, not only the mask, but we need N95, even respirator. Oh, we need to know how to handle AGP in this for instance. So we need to be careful in putting the patients. All patient with this, put the patient at the last. If we have 10 surgery on the day, put this patient at the last. And then, okay, before the patient undergoes surgery, the patient must be isolated in a certain room, isolation room. Okay, we'll go after this, yeah. So many of them, 10 from standard precaution plus 6 from TBP. Many of them are actually, some of them are overlap. Okay. By the way, this for the TBP, usually we have to be careful of this, yeah, the possible transmission, contact, either direct, indirect, using the format, using the instrument, droplets, and airborne. This dentistry very common, yeah. And then after we know, we need to make decisions. What we have to do, what we have to do with this patient. Okay, this we have to discuss among our team. Oh, put this patient at the last. Do surgery next day. It possible postpone. And then please prepare this PPE, for instance. Okay. Oh, make sure all of staff got vaccinations. Something like that. Okay. This can skip the infection control, maybe, yeah. This more so-called modern infection control. Yeah. Now, nothing new actually. We use the infection control, the standard precaution established 1996. Actually, this has been only been added. Yeah. Now, but in dental clinic, first you see here, before Second World War, like this, none of them wearing mask. Yeah. Even no glove. Now using ordinary mask, yes, surgical mask only. But COVID. Now we are still using this even after COVID if we are dealing with the patient with the AGP. How about in OT? Yes. What difference? Only now we need to have similar treatment also, similar setting also, but only change to be fit in the dental operating theater here. Yeah. Differences between general OT or general operating room and dental operating room, they are, if you can notice, yes, in the dentistry, we are dealing with the most of them AGP. Yeah. Okay, no doctor, no OGP. But anyway, the patient already got infection disease, right? Because we are dealing with the oral cavity, it's never been sterile. Impossible to sterilize our oral cavity from the patients. We don't know. Yeah. That's why different setting with the OT for the, say, for cardiac surgery. This must be 100% sterile. But for this oral cavity, for the dental operating theater, usually this similar like we are dealing with the urinary tract surgery, for instance. But differences here, we may use instrument that creating aerosol. Okay, just briefly what's going on and who are in the operating theater here. We have the specialist, the surgeon, and they want to highlight this. There is anesthesiologist, and then nurse, circulating nurse, scrub nurse. They are helping. Without them, no surgery can be done. Yeah. Okay. So the infection control, the purpose is mentioned a bit briefly mentioned at the beginning. We need to cut. Yeah.
Sorry, sir. Just
Yes,
remind 5 minutes again.
Okay, okay. Understand. Okay, this. Yeah. We need to break the infections chains. Okay. I can skip here. This we have to be understand at the beginning. Yeah. We have to cut, if possible, not only one, but as many as possible. We cannot rely only one step, but must be multi-step. Yeah. Okay. And then if possible, be eliminated. If not, this is the last we have to do. We have to do, yeah, using PPE. If possible, eliminate, because impossible eliminate, we have to replace with something. But PPE is the last. Okay. Now, what's happened in the operating theater here? look at this. Actually, not so many steps, only from 1 to 8. Hand hygienes. Yeah. We have to keep our hands clean. Yeah. I think no need to highlight anymore because you know how to do the proper hand washing. Yeah. This for the if we use the soap. Yeah. If we use rubbing alcohol. Okay. So there's some protocol also. We need to have certain protocol. So those who get allergy for this, setting different. Hand washing for the ordinary and hand washing for surgery, they are different. Okay? Much more complicated. This is the thing that usually many doctors they skip. So this is the duty of nurse to remind the doctor. And then PPE. This post-COVID-19 still same. If we know the patient are going to have AGP, we have to wear this, this setting. Still face mask N95. Cap everything, shoe covers. Yeah, if not like this, but still the mask. But we have to make sure we have to wear this. Yeah, not protect face shield. It's mandatory nowadays. No surgery without face shield. Okay, regarding the mask, if possible, at least we use N95. Yeah, this the right side is not so important. Yeah, as long as we have this and also face mask, the face shield should be okay. Okay, so this the protocol. The PPE must be kept and must be used using this protocol. Yeah, change any time for different procedure or different patient, of course. Okay, if possible, we use the disposable. If not, we have to make sure that's been sterilized. Okay, the gloves must be changed of its procedures before we have to wash our hands. Okay, make sure the gloves always intact. We need to follow the protocol how to wear gloves, how to keep gloves, especially sterile gloves. Okay, and then sterilizations and instrument processing. Here, there are two big. There's actually that cycle here for instrument processing, but they can be grouped into two: cleaning and sterilizations here. Yeah, cleaning is the first step, second disinfection, and then sterilization. Okay, so we need to know how to classify the instrument according to the use. So this critical, semi-critical, and non-critical. See, if critical item, no way, but we have to sterilize them. Yeah, this example critical item. Yeah, so we use for critical item usually like dental forceps. Yeah, for us. Yeah, scalpel, needle. Okay, so but to be honest, we have to follow this. Yeah, if possible, sterilizations. Don't do the inspection. By the way, what is sterilization disinfection? Yeah, sterilization is kill all microbes, including the spores, from material object. Disinfection just below that, kill everything but not the spore. Antisepsis is the lowest one. Okay. Cleaning. Yeah, about the cleaning. Yeah, cleaning is the first step must be done because if the instrument is still dirty, the microbe can be trapped. So this cannot be sterilized. Yeah, we can use either manual or automatic machine, but manual still be important if the instrument cannot be cleaned using automatic. Yeah? So somehow we need to do soaking here or brushing, or sometimes we need to do ultrasonic, something like that. Yeah. Packing, this to prevent the instrument from the contamination after finished sterilizations. Okay, this is how to do proper packing. I think this is the thing we have to learn and we have to keep ourselves updated. Yeah. For sterilization, usually we use autoclave. Yeah. Now, the autoclave, yeah, we use is the B class or pre-vacuum. Why? Because the instrument we are going to use now, the instrument got a lot of hollow. The thing that the air should be removed. Yeah, this is the only types allowed for sterilization now. The B class autoclave. Yeah, this follow this. Yeah, the most important is this time, holding time.
Sorry, sir.
Yes.
1 minute again. 1 minute
Sorry, can
again.
I have another 5 minutes?
Okay. 1 minute
Okay.
again. 1 minute.
Okay. I hit this. Now maybe we have to leave it now, and then chemical left because of environment issue we cannot do. This just for highlight this temperature. This some will use 3 minutes, the other may use 18 minutes. Yeah, we need to follow which protocol. Yeah. Then we need to monitor the sterilizations. Yeah, we use the chemical or biology. This must be monitored properly, and we have to keep in the proper place. Yeah, make sure we check the expiration date. Yeah, make sure of the package intact. Yeah, what about disinfections? Yeah, so we have to frequently disinfect the room, operating theater. Yeah, especially if the room has been used for the certain procedure with the patient with no infection disease, with UV. Yeah, okay. And then we need to know what kind of chemical disinfectant. Yeah, this I can share this. Yeah, we need to know the characteristic of the properties of the disinfectant. Yeah, there are 3 types: high level, intermediate, low level here. Okay, since if possible use the highest level one because we are dealing with the spore. Yeah, this is possible. But for cleaning the floor, we can use the low level. Yeah, this is the type of the from the chemical group. Yeah, from ethanol, glutaraldehyde, yeah, Clorox, something like that. Yeah. Okay, this is the strength of them. This is the highest, this glutaraldehyde group, and also chlorine. Yeah, Clorox in the high concentrations. So this how to handle the linen. Yeah, we have to follow the protocol. We have how we collect it and how do we wash to dry properly, and then packaging similar to instrument. This is the only way to do by autoclaving them. Okay. And then how to manage the waste. This is the one critical. Yeah, especially about when we handle the sharp instrument. Never pass the instrument directly hand by hand, but we have to use like intermediate. Yeah, like this. And then since we are dealing with AGP, so we need to handle how to if doctor need to using AGP, we need to use the high volume evacuator. How do we put the evacuator? Yeah, and then we need to make sure the patients history taking properly. Yeah, inside at the beginning we do actually. Yeah, the patient got infectious disease, so we need to put special schedule for them. Okay? And then the setting of the operating theater, we have to be careful not to allow everyone to enter this room. Only certain people can enter because they can be divided into special like protective and this aseptic zone. This only dentist, only doctor and nurse can enter. Designated nurse, designated doctor only. Yeah, that's what I'm going to say. It's traffic control. This is the responsibility of the nurse actually. Yeah, because many people come in and out. This will increase the infections. Yeah, since there's one publication said many people coming in and out, this will increase the airborne bacteria inside the operating theater. Okay, and then we have to regularly cleaning the rooms, especially after each procedure. This last year, we have so many protocols, but the problem is who will monitor that? Actually, it's the nurse responsibility. Yeah, doctor will do the job, but it's the nurse responsibility to remind the doctor, remind the surgeon. Okay. Actually, I can say that duty of the nurse here, a kind of like military police. Yeah, they control. They have the authorization to remind, to monitor. They not only do, but also they make sure the protocol is comply with the SOP. I can give example. This the protocol in UK. This mostly made by the nurse here, not by doctor, but by nurse. This in Malaysia also. This operating theater emergency system. This you see, most of them are operating theater nurse. Only few doctors here. Okay, so we need to comply with the duty of nurse to make sure we comply with the regulations. of course, because there's many updates, so we have to make sure ourselves, especially the nurse, to attend the education or training. In conclusions, so the infection control operating theaters, the purpose is to create the environment that minimize the cross infections, to put high standards for safe for the patient and for the us the staff. So this requires like collaboration effort from us, also the management on healthcare providers and surroundings. And we need to always update ourselves with the latest research and achievement publications. Okay, this it is the before I close this the
Okay, thank
place
you.
I'm working now in BD, yeah, nearby the beach. Yeah. With that, thank you for listening. I'm sorry for taking another additional
Okay,
5
thank you,
minutes.
Mr.
Okay.
Saladin. Give
Thank you very
applause
much.
for
Okay.
them. Luar
Assalamualaikum warahmatullahi
biasa.
wabarakatuh.
Yes. Thank you for Dr. Saladin for giving such the presentation. This is very important and interesting presentation. So all of the participants, you may make the question because this is very important. Yeah. So the we will three we have three question the first time. So please the admin, maybe you may uh, chat in the chat room. Yeah. A moment, please. Is there any? Hmm? Moment, doctor. Raise hand, you may. Okay. Okay. This is one question, Doctor Salahuddin. This is from PT GMI Pemalang, Miss Bayu. How we clean ourselves or sterilize ourselves after first dental operating theater when we still have two more operation?
Okay.
Yeah.
Yes. Okay. Can you say it again, the questions?
Okay. How we clean ourselves or sterilize ourselves after first dental operating theater?
Okay.
When
Okay,
we
after
still have two.
preparation, yeah.
Okay. Okay. Yeah.
Okay. Thank you for the question. As mentioned before this, we have to apply similar like the for instance, after we treat with one patient with one gloves, so we need to change our glove with new one for the next patients. We need to change our PPE. I mean, like that, if it's possible, like the gown. That's happen in operating theater. We need to go outside again, back to the preparation room. We need to again change our cap, change our mask, change. Yeah, we need to do the hand scrubbing again. Yeah, we need to change our gown again, operation, and then new glove, everything that's new. While during the time, the when the other nurse or the other assistant cleaning the area, disinfect the area. Just something quiet, troublesome, but this protocol we cannot avoid. We cannot avoid. Yeah? Consider we are dirty now. After we do the patient, we have been exposed with pathogens. So it means we clean ourselves. We need to get out from the operating theater. We clean since the beginning. No need to do wash. No need for us to do like bathing again, but just change. Yeah. Put new PPE. The simple way, put new PPE, clean, make hand scrubbing again, and put on new PPE. It is, did I answer the questions?
Okay, thank you, sir. And the second question from Siva Elsekem Unjani, Cimahi, West Java. The question is there any other way beside UV to sterilize the operating room?
Okay,
Yeah.
good question. Yeah, actually, there's one part used to be supposed to be in my slide, but I removed it. Yeah, because some country they don't allow it. Yeah, which is fumigations. maybe if you are familiar with this term, fumigation, 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 which is we do gassing of the operating theater using gas chemical. Yeah, but the problem is, after we do this, we have to evacuate the room for a while because of toxic gas there. But now they use fumigation, not fumigation. They just put something like hydrogen peroxide, something like active oxygen, yeah, something like that. But now I think UV is the best at the moment, yeah, because no environmental issue. But some countries like India, for instance, yeah, and Pakistan, yeah, they. But actually, I asked my colleagues in Brunei, yeah, they do fumigation. It is on the monthly base, But for UV, every day or after they have certain patient, yeah, patient that's been known to have like infectious disease. We just after the operation finish, so we need to clean and then we turn on the UV for a while, and then next the patient may enter. Or because this the only way they're safe, because now we can use the strongest chemical strong chemical as we can. The problem is an environmental issue. Yeah, visually the gas we use like glutaraldehyde.
Iki kok anyel banget toh.
Okay.
Did I answer the questions?
Yeah, okay, thank you, sure.
Ini,
Next,
Masya Allah.
Mr. Yonan. This is expertise from Bandung. Yeah. Please, silakan, Pak Yonan. The time for you to asking.
Okay. Thank you, Mr. Salikun. Do you hear me, my voice? Mr. Salikun?
Yes. Go ahead.
Okay.
Yeah.
Do you hear me?
Yes,
clear.
Okay. Okay, thank you, Mr. Salikun. Okay. Assalamualaikum, Mr. Solahuddin.
Waalaikumsalam wabarakatuh.
Okay. Okay. In this occasion, thank you. First of all, I would like to congratulate JKG Poltekkes Semarang and DPD PTGMI Semarang for initiating international webinar activities. I think this is very good and useful activity for delivering knowledge and sharing experiences from experts in the field of dental health. Before I ask, allow me to introduce myself. I'm Yonan Herianto, Mr. Solihuddin, and I'm a lecturer in the Department of Dental Health at JKG Poltekkes Bandung. And currently, I'm the chairman of the Indonesian Dental Health Education Association, and we call it ITKSG. From what explained of US expert presentation in this occasion related to handling infection control in dental health services after COVID-19, okay? It's very important, and in the world of education, we need to further improve. We need to further improve student skill of this. I have one question that I will convey to you, Mr. Solahuddin, and my question is, how can we improve student capability in the field of handling cross infection if we are facing the problem of limited practical equipment? Okay. And as we know that improving skill must be supported by complete facilities. I want to Dr. Salahuddin to provide answer related to your experiences you have had. Okay, thank you, Dr. Salahuddin.
Okay, thank you. The time for Dr. Salahuddin, please. Yeah.
Happy to hear that. Yeah, actually, it's expected questions. Yeah. Anyway, I deliver such kind of topic. The issue about the instrument and facilities material, right? Actually, like this. If you look at my presentation just now, none of them require very high effort. By mean that effort of like high tech nothing, but only the availability of the materials. Yeah. So for hand washing, that's important thing. You see the hand washing. Hand washing this, we don't need such sophisticated equipment, right? We need only antiseptic soap. We need only proper place, like for water. Yeah. If you don't mind, I can share like guideline, because some of the slide I took from the guideline from Red Cross organization in Switzerland. This to be applied in any countries, even war area, say like underdevelopment in Africa. So they have the certain protocol for that. And then, so if we cannot do we cannot use the disposable one, like gone, we can use the reusable one, but make sure we have the autoclave, autoclave and dryer, oven, If we don't have big class, actually it should be no problem, as long as we have dryer after that, or if not oven, we have to make sure they choose the material like cotton, material that's strong enough to be pre-processed, because if you follow the protocol and standard precautions, none of them they require high tech. And also, of course, we need like, okay, now said the facility is not enough, but I believe the facility should be sufficient. For instance, like disposable glove, glove. The glove, there are some glove they can be re-disinfect. Some glove, there are some glove can be re-autoclave. That's for whether we buy, if we have to think carefully, when we want to buy disposable glove and reusable glove. Maybe the reusable glove, autoclavable one, may be more expensive, but can be long lasting, right? Now they have to think about that. Look expensive at the beginning, but can be used for several times. Better than we use the disposable one. For mask, okay, maybe the mask of N95 very expensive. Okay, so you have to admit that that thing that's sometimes unavoidable, So, but for this now the situation after COVID, has been proved that the most important thing not only the mask but also the face shield. The face shield nowadays, we can use cheap material, right? And because we cannot autoclave, we can use simply disinfectant. If we have very good knowledge about disinfectant, you see some disinfectant, they are quite strong enough. I mentioned berglutaraldehyde, but many countries, they don't want to use this because of the environmental issue. So we can use Clorox, for instance. Hydrochloric acid, hypochloric, sodium hypochlorite. Sorry, mistaken. Like I say, high sodium hypochlorite or Clorox, we can use highest concentration for that. So this strong enough to destroy even the spore. Sometimes, like we can sometimes we can, if we have glutaraldehyde, it's good, but glutaraldehyde is very dangerous, also cannot be long lasting, but at least we can use the Clorox. Anyway, not all the bacteria we are going to deal, they are having spore. For virus, no problem. So far, virus easy to be killed. Virus, so far there is no virus cannot be killed using intermediate disinfectant. Even low level disinfectant is sufficient to kill virus. Usually virus no need to worry. The strongest virus we have hepatitis. But this can be killed using intermediate one. And I was saying just now is the high level disinfectant. That's why we need to have different site. As a different set of disinfectant. We have to use ethanol and then phenol. We can have Clorox or peracetic acid. This nowadays chemical not so expensive anymore. But for autoclave, this mandatory. I believe autoclaves become everywhere. Now no need to use expensive one. We can use made in this not high tech actually. We don't have big class. Should be no problem. I mentioned that they're only if we want to follow the protocol for high standard one. Of course, big class is mandatory. We go for the audit process, for instance. For audit, we check in hospital or clinic. For instance, they will check the first autoclave. What kind of autoclave do they have? The most important not autoclave, the monitoring. I mentioned just now, monitoring very important. After autoclaving, where do we put our instrument? But anyway, just to highlight also what you mentioned just now, attending only in the school not important. Not important. It will be insufficient. Won't be enough. We need to have another additional workshops. As a matter of fact, we need to attend such kind of workshop hands-on regularly, not only once in the one semester. What we have to do it regularly. Even those already, for instance, in the institution, even the nurse, after they finish their working, they need to attend. At least once a year, at least, because we don't know, right? We may forget. There is new technique or maybe simple technique. Yeah, even I'm still learning this. When I just update preparing this slide, hey, no regulation. Oh, no need to use this, no need to use that. Should be no problem. Yeah, of course, if we have to know the minimum requirement, yeah, like I said, we need collaboration from because you are running a school, yeah, we need collaboration not only from our colleagues in the health area, but also we need management from other, yeah, from government. If the government support it, we need to tell the government we want to follow what comes standard. We want to follow. We need to follow international standard or local standard, and we need to know our area. Our area, many of our area, are we going to serve the patient with infectious disease? Yeah, especially we are worried about now the antibiotic resistant pathogen, something like that. But inshallah, this should be no big problem. Yeah. Okay. Sorry, did I answer the questions?
Okay, thank you. What do you think about Payonans? Okay. Luar biasa. Yeah. Okay, thank you. This is very important for the answers from the Dr. Salahuddin. We want to conclusion of this meeting that effective infection control is important. Looking back to the history, the infection prevalence was found in 19th century in the dentistry itself. So all the people here have to understand to the history. So we have to look at the behind to be successful in the future. Next, Bu Hermin, you want to keep something?
Okay, thank you for Dr. Solahuddin Jauhari Arif Ikhwan. Before we go to the next agenda, we will hand over the certificate for Dr. Solahuddin, which will be displayed virtually. For you.
Yeah, thank you very much.
Salahuddin, thank you very much. Thank you for your time. We hope you can follow this agenda until the end. But if you have another agenda, please feel free to continue. Thank you very much.
Okay,
thank you, Dr. Salahuddin.
Actually, just like to ask permission because I need to go check out.
Terima
I will
kasih.
continue my journey. Yeah.
Okay.
Mr. Salikun, time for you to the next speaker.
Yes, good. Next, ladies and gentlemen, we know it's for the second speaker. Therefore, please welcome Prof. Aris Naris. How are you, Prof? Can you hear my voice?
Very clearly. Can you hear me?
Thank you. Yeah. Okay. The time now to you, it's about 30 minutes. Then after that, we continue to question and answer. Okay. The time for you. Thank you.
Yeah. If I can have my slides on the screen, please.
It's okay. Okay.
Unless I can screen share from here.
You mean from mine or from you? From here,
yeah,
I mean.
I'll share from my side.
Okay. Oh, yourself. Okay. Yeah, from him. About yourself. Yeah. Please, you try.
Okay. Can you see my slides now?
Okay. Yes. Okay.
Yes. Okay. Thank you for having me. Assalamu alaikum, everyone. And it's always been a pleasure to be part of the Indonesian health service presentations since I think I've spoken at multiple events probably since 2019, and it's always been a privilege for me to be part of things. So I'm a restoration. I've had various roles within the Australian and New Zealand health system. I trained in Fiji for my oral health, but I have had the privilege of completing a lot of my programs through Harvard, London School of Economics, and so on and so forth. I've worked in a very large tertiary hospital during COVID when called the Royal Adelaide Hospital. We had more than 1,000 beds there. So my experiences today is about the evolution of infection control, the past, present, and the future. I think what I'm trying to cover off is, while a lot has changed, a number of things that we do are still the same as what was done many, many years ago, and the importance of things like that. The speaker before me spoke about hand hygiene a lot, and I cannot emphasize how important that is going forward. And that's not just because of COVID. Hand hygiene allows us, even in our homes, to prevent a lot of infections. So, what's the premise of everything that we do in dentistry and healthcare? Now, if you look at the Hippocratic oath, it's about first do no harm. We as clinicians, we as people, we don't want to create harm for anybody ever. And in our role, people trust when they come and see us. So since the beginning of modern infection prevention, the earliest days was around 1847, when a Hungarian physician and scientist called Ignaz Semmelweis realized that the reason so many mothers were dying of puerperal fever in his hospital was because doctors were going straight from performing autopsies in the mortuaries right into delivering babies. And when he instructed that the hands be washed between the two procedures, the death rate dropped dramatically. What was happening is people was doing the autopsies and just going in and delivering babies without washing their hands, thinking that their hands were clean. But what they were doing is, because they were introducing all the dead person's bacteria into the to the baby, and the baby was dying. So that in 1847 became the first time it was demonstrated the infection could be caused by healthcare professionals, and there was a way to prevent this, and the easiest way was to do hand washing. And as the speaker before me said, that's called healthcare associated infection. So why we did effective infection control? So this is a very recent data from the World Health Organization in 2022. It says, today, out of every 100 patients in acute care hospitals, 7 patients in high-income countries and 15 in low and middle-income countries will acquire at least one healthcare-associated infection during the hospital stay. On average, 1 in every 10 affected patients will die from healthcare-associated infection. So basically what it's saying is that a lot of people that come to see us end up dying, not a large proportion, but a significant proportion, still end up with more infections than what they first came in. They may have come in with a minor knee surgery and ended up leaving with MRSA associated infection. So that's why HAI is the thing to prevent when we think about infection control. And if you look at the field of dentistry, now for many years, dentistry wasn't seen as a novel profession like medicine or pharmacy or teaching. A lot of the people doing basic dental procedures were based in barber shops, and they were not doing anything that was scientific until Pierre Fauchard, who is known as the father of dentistry, started writing the first complete scientific description of dentistry, which he called Le Chirurgien Dentiste, which means the surgeon dentist, as early as 1728. And before Fauchard discovered all that, barbers or tooth pullers would do this instead of doctors, and they would use pelicans to draw teeth. And imagine the horror. These pelicans were not very precise. So what would happen is they would pull out the healthy teeth along with the problematic ones. And because there's no way to gauge how much pressure is being applied, sometimes they would even pull out the jaw. So imagine the infection control issues that was happening during this time. So all of this combined, Pierre Fauchard then wrote a lot of manuals, and he also came up with the now famous dental drill, and also came out with an understanding that there is an issue with airborne infection. So we talk about droplet precaution, we talk about aerosol generating procedures in dentistry. Well, this wasn't just discovered during COVID. It was as early as 1864, precisely on the 7th of April, 1864, when Alexandre Dumas, a French biologist, called Louis Pasteur, who later came up with the pasteurization technique, proved that microorganisms existed within the ear. Until then, people didn't really think that there were bacteria in the air or other microorganisms that cause infection. At that time, Glasgow-based surgeon Joseph Lister saw these findings and saw how significant this was. And as you know, Lister is one of the people behind modern infection control. He came up with the antiseptic or antisepsis procedure. So in a series of articles in the Lancet and in the British Medical Journal in 1867, he described how these microbes could be prevented from causing infection by the cleansing and covering of a wound with the carbolic acid, phenol sulfate, and carbolic acid, linseed oil, and carbonate of lime putty mixture. That actually became what you now call the first antiseptic. And after using it for 9 months, he said that not a single instance of pyoemia, hospital gangrene, or other infections had occurred in the patients. And although this was experimentation and his thinking was not universally accepted for many years, the idea of antisepsis was taken up and reported in 1876. And this is the first time in dentistry antisepsis was formally mentioned, and this was done by a London dentist called Ashley Barrett. In her paper in the Odontological Society of Great Britain, he described how he used the practice in root canal therapy by cleaning and then filling the pulp cavity and interior of the fangs, as he called them, with wool dipped in carbolic acid, followed by placement of permanent metal filling over the top, thus preventing further infection. And nowadays we are using more advanced materials like using hydrochloric acid and sodium hypochlorite to clean canals and surfaces, and also putting in things like pulp and other medicaments to clean the canals or prevent further reinfection. But these were the early days when he was using carbolic acid. He further went on to describe how he treated chronic periodontitis, a term he used to describe chronically infected pulp and abscesses by pores of carbolic acid used to mop out the interior of the tooth. So a lot of the things he was describing was how to clean the tooth as much as possible, following the products of decomposition from the walls of the pulp cavity. Just remember, in those days, they didn't have access to high-speed drills or high-volume suction. So as they were cutting into the teeth, they were ending up with more debris on the floor and on the wall of the cavity than what we do now. Thus, he demonstrated the prevention of putrefaction of the dental pulp after devitalization by arsenic and showed the arrest of putrefaction of the dental pulp when once established so directly during periodontitis. So this was the first time that dentistry started mentioning and using anything close to antisepsis. Until today, we are doing a lot of the procedure using the same antiseptic techniques. Now, the wearing of dental gloves or gloves in general, this wasn't a new thing. Now, this is actually quite an interesting and funny story because following Semmelweis and how he had, and you need to remember this name now, Semmelweis was the father of hand washing, advocated the disinfection of the hands. This meant a lot of the skin was being disintegrated. It was taking a toll on the skin. And you know, a lot of us have different types of skin. Some people have more sensitive skin. And because of that, they were starting to have cuts, abrasions, dry skin, and other dermatological conditions. And at that time, the American surgeon William Hosted's scrub nurse Caroline contracted severe dermatitis as a result. He decided in the winter of 1890 that as she was an unusually efficient woman, he would request the Goodyear Rubber Company to make us an experiment of 2 pair of thin rubber gloves with gauntlets. Now, those you know, Goodyear now is supplier of car tires. So if you think about dental gloves or gloves in general and where they came from, please remember that the innovation didn't come from healthcare. It came from a tire making company. But it is so important today. They were so successful, but that not only did he later marry her, but the wearing of gloves by theatre assistants became more increasingly in the common. Surgeons did not start wearing them until Dr. Joseph Bloodgood published a report in 1899 showing that after he had tried it with a subsequent near 100% drop in the infection rate following hernia operations performed by him of the year. Despite this, sterilization of hands is in evidence in dentistry, but not gloves, as can be seen from the minutes of the National Dental Hospital in London in 1900, where dressers are told to dip their hands in perchloride of mercury before putting their fingers in mouth. So gloves, even though it was being used in other parts of medicine, was not being widely used in dentistry for a while. The other major, moment in dentistry was syphilis and dental instruments. Joseph Lister, by now, was very prominent in this space, and he argued that the disinfection of surgical instruments was not widely practiced. In 1891, the American dentist Willoughby Dayton Miller published the disinfection of dental and surgical instruments after a growing concern that syphilis was now being spread as a result of dental care. So then he suggested that napkins and rubber dams that were used in dental procedures should be boiled, although he wasn't a fan of the reuse of these products. So at that point in time, people were reusing rubber dams, and thankfully we don't do that now. But he suggested that they can be boiled and reused, even though he would have much preferred that they were discarded. And at that time, instruments could not be sterilized by dry heat because of the length of time it took, and after much experimentation with chemicals, he concluded that the best means of sterilization for them was boiling water. Now, there was a question by somebody for the previous speaker about, how do you manage all of these things in developing countries or when you don't have enough materials? Just remember, use a risk stratification matrix. If you do a good risk assessment of your patient, then while I'm not saying that it's best practice not to autoclave instruments, but you can get away with boiling instruments in some circumstances, depending on the risk of the patients and the whole group you're treating with. And in this article, he also asserted that whatever the method of disinfecting we may use, the instruments should first be cleaned mechanically, and thus was one of the earliest to recognize that reducing the bioburden on the instruments greatly facilitated the effectiveness of the sterilization procedure. And nowadays, we either scrub the instruments or we put them in biosonic cleaners to introduce the mechanical phase. And until then, there was very little use of autoclave in dentistry, even though the the invention of autoclave was as early as 1879, it took nearly 80 years before dentistry started using autoclaves because the WHO until then had not recommended the use of autoclaves and had recommended that chemical disinfectants should be used for invasive surgical instruments. Until then, the cost of the autoclave was also astronomically high, and as a result, it wasn't suitable for the everyday dentist to be able to afford it. So the cost of the autoclaves fell through the 1950s and became increasingly affordable for the general dentist. And now, if you look at what we do in our practice, we are using Class B autoclaves with data loggers. We are labeling the instruments, critical instruments well. We are using autoclaves that have a drying cycle. All these things have come about, but they were not present in the early days. So the use of autoclaves and its upgrade has been a great, I would say, gift to modern dentistry, because now we can prevent further reinfections because we're using better products. And a lot of people didn't know that mouth was a source of infection. We know that. We know that now. We know that mouth is the window to the body, and we introduce bacteria. But in early days, this wasn't known by the wider sector. So the knowledge of aerosols, even though it's not new, was not well understood. Lister used a machine that sprayed aerosols of carbolic acid to create an antiseptic operating environment. And this is probably similar to the fumigation word that the previous speaker spoke about. As far back as 1884, Robert Koch showed the adverse effect of oral aerosols by proving that tuberculosis could be transferred by aerial droplets from the oral cavity and the respiratory tract. So after this was discovered, that syphilis was spread to dental clinics. They also found that through dentistry, that TB was spread through the air. So dentistry has actually given a lot to the modern medicine and healthcare sector through its discoveries. Later in 1891, the toxic properties of saliva were referred to by W.D. Miller in a series of articles in Dental Cosmos about the mouth as a focus of infection. The consequences for dentists were not appreciated until in 1931, a report by the Register General of Great Britain showed that airborne infection and incidence of tuberculosis was higher for dentists than for people engaged in other occupations. Despite this, nothing was done to protect the dental team until the introduction of ultrasonic scalers and high-speed turbine engine in late 1950s, similar to the time when autoclaves were also introduced. And then they came up with the following recommendation, that we need to water on rotor method, we need to use rubber dam routinely, we need good ventilation, we really need reduction of residual water accumulation or flushing of water lines. We need to use pre-operative mouth rinse, we need to use masks and glasses, we need to use high velocity suction, we need to disinfect our burrs, we need to wipe down all knobs and handles, and we need to spray the operating area. This was the 1950s. Now, if you look at that list now, apart from a few things that we've added on because we've understood the science better, the large part of what we do in dentistry hasn't actually changed in terms of infection control. So even back then, they had a good handle on things. And then there was another watershed moment in the 1980s when HIV/AIDS became a big issue. And with that, there were increasing prevalence of hepatitis B and C. And as you know, those three, I suppose, conditions are things that we have to encounter in dentistry more, especially Hep B and C. While HIV/AIDS needs more blood transmission, Hep B and C are spread through saliva, and we deal with saliva every day. And they found that the barrier protection in use of autoclaves rather than boiling instrument was good. Another problem was of biofilms in water, and this was highlighted by M.V. Whiting in 1987. What he wrote in an article is that microorganisms could be transferred to patients as a result of dental treatment via the dental unit water supply. This led to the introduction of anti-retraction valves, which we now have, and various measures to improve the quality of dental unit water supply, such as the use of bottled water and regular flushing and disinfection of units. I would also like to advocate here that you should always use good distilled water in the water lines, because often I've seen people fill water from the tap and use that. That comes with a lot of impurities, and it is becomes a reservoir for breeding bad bacteria and organisms. So please, as much as possible, always flush the water lines and use clean distilled water. And you'd be surprised that even though all of these professions had been operating for so many years, there were no formal guidelines. The first actual mention of formal guidelines in dentistry was not until 1991, when the British Dental Association members did at least have an advice sheet called the A12, which was on the control of cross-infection in dentistry. And that became the most requested advice sheet because there was nothing else like it, until the fear of prions came about. And as you know, prions was based on the mad cow disease. And that led to a lot of changes in how we autoclave, and then they moved the autoclave temperature to 134 degrees for 3 minutes because they found that while bacteria died at a lower temperature, to kill the prions, it needed longer time. And if you look at how things were from the early 2000s until COVID, a lot of the things in infection control, apart from improvement in the type of materials we're using and more sustainable products and more products that were better for the environment, a lot didn't change until COVID-19. And you won't be surprised that personal protective equipment is not new phenomenon. We've grown up seeing images of the big plaque doctors of the past, which is on the right of the slide. It looks something out of a horror movie, but if you look at COVID and how we were dressed, we were dressed in a much similar way, just with modern guns and better equipment. A Colorado doctor recently published his thoughts on medieval figure with its grotesque wig, with head covering, covered eye holes, wet strobe, and cane before and after his first approach to a patient dressed in similar garb of the hazmat suit, gloves, goggles, and respiratory mask that we used in COVID-19. So, as I said, a lot hasn't changed in that space. And during COVID, we largely went back to what we were doing before. But because this was a deadly disease and we understood it less, we then started with using the risk stratification model a bit more. We went with all of the things. We went through every PPE that we had against the problem and then kept scaling back as we understood the disease better. So essentially what is happening now is that we are not wearing all the hazmat suit for every patient. We have a vaccine for COVID. People are building natural immunity. So what I'm trying to say here is that when a new infection or a new disease is discovered, we always go to the high risk area of the disease functions, then we scale back down and go down the risk stratification model. So always use risk assessment and risk stratification in the way you plan services and you plan things on a daily basis. So the concept of quarantine is also not new. while we had quarantine for 28 days, and some people in some countries, the quarantine was for way longer. The concept of quarantine also came very early on, as early as 1377, when the Adriatic city of Ragusa in Italy had a lot of ships coming with people with the Black Plague. So they stipulated that people should be quarantined for 30 days, and that was known as quarantino. And later on, the quarantine word came from the descendant of the word quarantino, which is a word to say 40-day period in Italian. And the health officials officially prescribe a 40-day quarantine because the number had great symbolic and religious significance to medieval Christians. So if you think that the quarantine phase at that point was scientific, it largely wasn't. The 28 days COVID isolation was, but the quarantine period first came from biblical terms because God had, as per the Bible, had flooded the earth and it rained for 40 days and 40 nights. And Jesus fasted in the wilderness for 40 days. Even in early days of medicine, there was a 40-day purification. So after childbirth in those times, a mother was expected to rest for 40 days.
Sorry,
So
sir.
I will show you.
Just
Yes.
remind, sir. 5 minutes again.
Yeah.
Okay.
Yeah, I'm nearly done. So I'm just going to show you a checklist, which I won't go through because I have got this link. So this is a checklist that has been developed by the Australian Health Regulatory Association in consultation with the Australian Dental Association. Basically, you can download this checklist online from the link that I'm sharing. Hold on. So the link is here on the top. And I think if you want to see how your practice is actually working for infection control standards, you should take this checklist and then fill your responses against it, or getting someone independent that knows how to use this well and then use their expertise. And you'll find that you can review your service, your practice, and be quite modern after using this because you can develop a good plan. And I'm very happy to assist any service or any polytech to do this, on a pro bono basis. I'm ready to be helpful. So in conclusion, in exploring the history of infection control, it can be seen that all tenets were discovered or rediscovered in the 19th century, and yet it took over a century for this findings to become everyday procedure. It is that procedure built on the accumulation of evidence that will protect both patients and the dental team now and in times to come. It is that procedure built on accumulation of evidence that will protect both patients and the dental team. Evidence-based dentistry or healthcare is key to future infection control. So before we move to the questions and things, my email, I know some people want to ask questions in the forum. My email is here. If you want to ask me any questions, if you want me to send any resources from Australia and New Zealand, send me an email and I'll send them to you. And I'm also very happy to come to any of the polytechs and help them with the audits or do some lectures for them in person in future. I've had a good relationship with the Indonesian Oral Health Therapy Association through the time when Zaini Dahlan was president, and I've always been looked after him, and I consider him a good friend. So if I can help the Indonesian Polytechs in any way, I'm happy to do that at my cost. So if any Polytech wants to, they can email me and we can set up a way. And now I will hand it back to the moderator for any questions.
Okay, thank you, sir. Thank you very much, sir, for giving us very beneficial information. So actually, many questions from the student, also the dental therapist. So I would like reach the question from Muhammad Aziz Rahman from Surabaya Islamic Hospital. Are you ready? Yeah. This is from the question to Prof. Anis Nares. The question is, in your opinion, in there any special standard for us as a dental professional to dealing with the development of infectious disease in every decade? I mean, what standard it must to be considered? Sure. Thank you.
Thank you. That's a very good question, and I think it's a very progressive question because there's two things here. In my presentation, I talked about the checklist. So I think the first thing to do is to review your practice or your organization using the checklist to discover where you are against the general standards. And in my last slide, where I've put down further readings, there is a infection control standard from New Zealand, which is about 30 pages long, but it describes every procedure with the gold standard. It then describes what you can do when you can't meet the gold standard, and also the steps you can take to build up to that standard. So two things I would advise: do the audit of your practice using the checklist, and then compare it against the standard that I've shared for New Zealand and see where you stand. And I'm happy to then review it, even if you send me email of what your current practice standard is. I'm happy to review the article for them.
Okay, thank you, sure. Muhammad, can you understand what the meanings? Okay. Yeah. Okay. This is very important for the presentation. When do you go to Indonesia, sure? Maybe you drop in Semarang. Okay. Because
sorry, I missed the last part.
Yeah. If you go to Indonesia, you may drop in Semarang, I think, because many students waiting for you to your science like this one. Okay, sir.
I'll be very honored, and so if someone can contact me with the what time of the year is best, I will make a trip there, and I will not only teach infection control, but also science of dentistry and other things at the same time while I'm there.
Okay, thank you, sir. So, according to my opinion, that conclusion for me, effective infection control is important. Looking back at the history, the infection prevention was found in 19th century. In the dentistry itself, mouth is the source of the infection. And according to some research, it is recommended to use such as water on air, rotor methods, rubber dam, use good ventilation, and preparative mouth rinse. So this is very important to us according to your presentation. So is there any other question from participant? Is there any question? Is there any question again, maybe? If no, I think thank you very much for Professor Aris. So the time to MC, please.
Before we go to the next agenda, we will hand over the certificate for Professor Aris Naris, which will be displayed virtually. Thank you, Professor Aris Naris, for the very precious presentation. Please remain on the screen. We will. Okay, it's okay, Mr. Salikun. Time for you to the next speaker.
Okay, thank you, sir. Yeah, very important for this presentation. So once again, namely, ladies and gentlemen, now please welcome to the third speaker, namely Dr. Naikla Survey Andiesta. She is from the Malaysia. Hello, Dr. Naikla. Can you
Hello,
hear?
hi,
Okay, thank you.
Dr.
Terima kasih. Terima kasih. Yeah.
Okay, yeah.
Today, Dr. Naikla will present such interesting topic material about the prevention and control of cross-infection at dental laboratory. So, the time for you.
All right, let me share my screen before I start, yeah?
Okay, yes.
Okay, everyone can see the screen, my screen?
Yes, ma'am. Okay, go ahead.
Thank you.
Yeah.
All right, so I will start with the title. Okay. Assalamualaikum warahmatullahi wabarakatuh, and good morning, everyone. I'm Dr. Nikla. I'm originally from Indonesia, but I'm now currently working in the School of Dentistry in IMU, International Medical University in Kuala Lumpur, Malaysia. I've been here for like more than 10 years, yeah? Okay, today I'm going to share about the cross-infection prevention in the dental skills lab. Maybe you're wondering why my presentation specific for the dental skills lab. Let me giving you some background for it. Yeah, dental skills lab. That is something that we have it in our school for the students to get or to develop the habit, the good habit before they go to see the patient. And then the skills lab follow all the protocol or the guidelines according to the Malaysia guidelines for dental laboratory. Okay, so what I will share this is according to what I practice or what we practice in our school. But don't worry, it will be similar with the dental laboratory cross-infection prevention. Yeah, it's not many difference. In fact, in dental skills lab, the cross-infection prevention is more detailed because we need to teach the students. Okay. All right. Okay, this is our campus, International Medical University, or in Bahasa Melayu, University Perubatan Antarabangsa. Okay, and our outcomes today is we will discuss the potential resources of cross-infection in the dental laboratory, and to discuss also cross-infection in dental laboratory in terms of prevention. Okay. Okay, so our dental skills lab in the School of Dentistry in IMU, we have what we call it as dental skills center. Dental skills center, there are two dental lab. One is DTL or Dental Technology Laboratory, and this picture is Dental Technology Laboratory. So this is the place where the students do everything with related to the prosto and ortho, yeah, something that they need to do, something like denture or appliances. Okay, and the other one is DSL. This is DSL. This is Dental Skills Lab. So this lab is for the every restoration procedure. So we use the mannequin here for the students to practice. If you see this picture, actually this is before pandemic. Okay, so before pandemic, we have already what we call it dress code, and we have already what we call it a protocol in dental skills center or dental lab. Okay, they need to wear lab coat, okay, long lab coat that we provide, the school provide the lab coat, and they need to wear pants. Yeah, so they will work together in pairs because we will practice a four-handed dentistry in oral health center or in the dental clinic, and they need to wear a mask, they need to wear gloves, and etc. And they need to tie their hair if their hair is long. Yeah, even if we don't, uh, 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 we are allowed the male students to have long hair, but we want them to tie the long hair accordingly. Okay. But after pandemic, of course, world is changing. Yeah, world change a lot. Not only us, but everywhere in the world, we change. We put the additional means in dental skills lab. The additional means is the face shield and the goggle. So that two now become mandatory for them to wear. Yeah, it's different with the dental clinic. Dental clinic, they need to wear PPE, they need to wear head cap, they need to wear a shoe cap, shoe cover, and etc. Yeah, besides the face mask, and then face mask also they need to wear the respirator like N95 for dental clinic. Okay, specific mask that we need to use for practicing dental procedure, yeah, in the dental clinic. All right. So in dental lab, everyone, I said everyone, not only students, we need to wear this. Dental technician, lecturer, everything, everyone. Yeah, not only the lab coat, not only the gloves, not only mask. Yeah, then we need to wear this. It's mandatory. Okay, this is we change, and then it still implement until now. Okay, we will still use this additional means for them to use. Okay, now we talk about what is actually potential resources of cross-infection in dental lab. Yeah, we know, we can say dental laboratory is considered as a low risk for cross-infection, but it's not zero. Okay, compared to dental clinic, dental laboratory is low risk. Yes, but it's not zero. Just remember that. Okay, so there are few things that have a potential of cross infections. One is mannequin, and the one is the impression, dental impression, and the bite registration, and also the handpiece, the burrs, yeah, slow speed, high speed. Even we use ultrasound scaler, yeah, for students to practice to do the scaling. Okay, so everything actually we can say that is a potential resources of cross infection. Okay, so not only that, on the left side, the blue one is the what we call it. We use for put the tray. We call it as a tray with the cover. We put the model and everything inside that. And the other one is, there is a articulator, and also there is a polishing a pumice to polish the denture and etc. Yeah, that's also have a potential of a cross infection. Okay, so when we know what are the equipment or what are the material that have a potential cross of infection, then we know what to do about it. So I believe in Indonesia, I believe you have the guidelines from the Ministry of Health that become a gold standard, like what Dr. Arish just now mentioned, that there is a gold standard from the government for us to use, for us to follow and create our own SOP. We have to match that gold standards. As when I say here, we use Malaysia Dental Council, the guidelines for occupational safety and health in dental laboratory, and also guidelines for infection control in dental practice. Yeah, so our reference is there, but we have our own protocol, yeah, that match that gold standard. All right. So I don't have to talk about then the contamination, disinfection, sterilization. The first speakers already talked about it a lot. So I will make my presentation is just short and sweet. Okay. You know what the decontamination, you know what disinfection, and you know what sterilization. Yeah. In dental lab, we don't really do the sterilization, correct? Yeah. Because we don't really use autoclave, because we don't really deal with a human fluid, different with the dental clinic. Yeah, we deal with the human fluid, human blood. Okay. In dental lab, we don't, right? So we don't talk about sterilization for dental lab, but we talk about decontamination and disinfection. How actually we can make that low risk become zero risk. That's actually the point of the prevention of cross-infection in dental laboratory. Yeah, we don't want something from low become moderate or high, but we want the low become lower and lower and lower and become zero. That's actually our objective when we talk about prevention of cross-infection. All right. So I just want to talk about the contamination of mannequin, because the students are, I believe in dental lab, dental laboratory, commercial dental laboratory, you don't have the mannequin. But I want to just to touch a bit about mannequin decontamination, how we do it in our school. Yeah, before the sessions. Okay, it's the staff job to check whether the mannequin is visibly dirty. Yeah, if visibly dirty, then we need to wash. They need to wash with the soap and water and dry thoroughly with paper towel. Okay, so usually the staff in dental skills lab, in dental laboratory, will check about all the equipment in the laboratory before they use or before that equipment or anything that in the dental laboratory be used by anyone. Okay, but if there is no visibly dirty no visibly dirty, then they just need to wipe with the alcohol wipe and dry again with the clean paper towel. So usually the students will do it. Okay, usually the students will do the wiping the face skin of the mannequin before they start. Okay, and then they do whatever they need to do during the procedure, and then after they finish, after the session, they should clean the mannequins using gloves, because they have already used the gloves. Yeah. Okay. Using gloves as soon as possible at the end of each class. Rather than that, it's not only mannequin that need to clean, but also the handpiece. Yeah. And also the suction. Yeah. Basically the unit that they use for practice. They need to clean, they need to change the water, they need to make sure the water is sufficient for the next session, because the next group of students will come and then use. So everything is mandatory for them. Why we make it mandatory? Because we need to be sure that they develop a good habit in terms of infection control, yeah, to the dental clinic later. All right. So it's not only mannequin they need to decontamination, but they have to also do decontamination for the handpiece, the birds, anything they have already used in the session. Okay. Now, as I mentioned you before, it's about impression, bite registration, and etc. That already they do it in the dental clinic before they send to the laboratory, the dental lab. Yeah, they need to decontaminate the impression or bite registration or whatsoever. Yeah, because it's already touch this the mouth of the patients, and it already have some exposed to the fluid and maybe a blood or something, right? So I don't put this in the okay, it has to come here. Wait, sorry, yeah. The first one, it has to clean, the impression or the bite registration has to be clean or washed under the running water. Yeah, so actually it's in the third picture. I'm so sorry, I did not put in the sequence. I will modify it later, yeah? And after that, after they wash it under running water, they need to spray with the disinfectant. We use sodium hypochlorite. Okay, on the second here, I hope you can see my cursor. Yeah, this one, right? So after they spray with the hypochlorite, they need to cover with the damp paper towel. Why we need to make? Why we have to use the damp paper towel atau a little bit wet of a paper towel, because we want to keep this impression to still moist, not become dry. All right. Then after they cover with the damp paper towel, they need to put in the plastic with the seal, plastic wrap. Yeah, it has to be with the seal. Then only they send it to the dental laboratory. Okay. So in the laboratory area, dental laboratory area, there are 3 areas. That's a mandatory according to the guidelines from the MOH Malaysia, that they have to have 3 areas. First is receiving area, second is production area, and the third is delivery area. Receiving area is the everything cases from dental surgery are received and that in that area, at that area, and handled and again disinfected before it transferred to the production area. So meaning, just say that impression has to be cast, right? We need to cast it with the what we call it, with the plaster, right? Yeah. Then we have to disinfect first, even though it's already done by in the dental clinic. But still, when they open it, of course, they need to use the gloves. They need to use the face mask, that the mandatory outfit that they need to wear in the dental laboratory. No one can work in the laboratory, dental laboratory, without the mandatory outfit like dental, we call it the lab coat and etc. Okay. Then after this, disinfected with again the hypochlorite, sodium hypochlorite. Then only, yeah, they open it from the plastic, right? And then they remove the paper towel, and then they hold it, and then they disinfect. Then only they transfer to the production area. Production area, there are 2 areas, wet and dry area. To the wet area of the production area, to cast it, become a model. All right. So wet area is everything related to water. Dry area, there is no water involved in that. Okay. Then after they finish with the whatever they need to do, like a denture or appliance in that production area, okay, they will put that into the delivery area. The delivery area is where denture or appliances should be stored. Okay. Then before they start, all the items should be disinfected before being sent to dental surgery. Just say, I have already shown you about the tray with the blue one in the previous slides, right? With the cover. So usually they put everything in that cover before someone taking it or deliver to dental surgery. And then before they deliver, they open it, they take it out, they disinfect it, and they put in the some another tray. Then only they send to dental surgery for the patient. So everything, like, we just need to make sure everything is follow like that. So in the dental laboratory, all the persons who are involved in that procedure or in that production of the dental technician, they have to know the protocol and they have to follow strictly. So when students come and then they just give the impression or bite registration or anything to dental lab, students also needs to know the protocol, and the dental technician or the dental nurse who are in charge for dental laboratory will be the person who always monitor whether everyone follow the protocol. Okay. Now, this is the additional part that in dental skills lab, yeah, we sometimes need human extracted teeth for students to study, yeah, to do the practice on the human extracted teeth. How to handle it? Yeah, there is a protocol that we need to follow. Yeah, the teeth first has to be clean, right? Scrubbing with detergent and water, or maybe ultrasound cleaner. Yeah, just to clean everything. Okay. Then after that, they need to be immersed in the fresh sodium hypochlorite. Yeah, it's 1:10, the ratio. We know that, right? I don't think I have to go for this. Okay, so immerse that in the store, in the container, all it. After they clean, yeah, of course we need to use the glove and everything. Okay, then it mentioned in the next part is the person handling extracted teeth should wear gloves, face shield, surgical mask, and protective eyewear. Okay, and as usual, we know gloves should be disposed properly, and we have to hand wash after completion of the work. Yeah, hand wash, hand wash, hand wash. That's like a keyword, and then that's also a golden standard for us. Yeah, and the work surfaces and equipment has to be clean and decontaminated with the liquid chemical germicide, yeah, or with any disinfectant after completion of the work activities. This is how to handling human extracted teeth in the lab. I'm not sure whether in the Poltekkes you have the dental lab to handle the human extracted teeth, but this is something that we do in our school. Okay. The other one is actually the amalgam waste management. Yeah, because we have a practical for students to do the amalgam restoration, right? So they need to know how to waste the amalgam.
Sorry,
and
sorry, ma'am.
Yes.
Just remind 4 minutes again.
Okay. Never mind. It's almost done. Okay, so amalgam waste management, we don't rinse amalgam or the amalgam capsule in the sink. After we use, yeah, right away we store in the designated container and has to be airtight and labeled that is mentioned amalgam waste. Right? So we cannot wash whatever after and then we just say, okay, oh, there is some remaining of amalgam, and then we just want to just throw it away on the bin. No, you cannot. You have to put in the amalgam waste container. Okay. Yeah, I think that's all. So this is the references. You just need to look at it. Everything I just follow whatever it's the written in the guidelines from the Malaysian Dental Council, which is already approved by the Ministry of Health Malaysia. Okay, for that, I will end my presentation and get back to you the moderator. Thank you very much.
Okay, thank you, Dr. Naikla. We have time to question and answered. So please, of all of the participants, you may asking by direct or my or chat room, please.
Yeah, thank you.
This is very important, I think, because the dental laboratory, especially for the dental technician and also the dental therapist, can be overcome to our activity in the dental clinic. So you may ask the session to Dr. Nekla. Yeah, please. Okay. While we waiting for the question, I would like to make the conclusion. I think, according to my opinion, the cross-infection prevention in dental labs can be provided by means of face cells, and also in order to recommend disinfectant and also sterilize all types of microorganism. There are procedures to do this, and most important, we as the dental team must understand each of the steps to ensure human safety survives dental health.
Yes,
Yeah.
I totally agree with you, Mr. Moderator,
Yes.
because we are the health providers, then we have to really strictly follow the protocol. Yeah.
Okay. This one, there are some of the dental student in Polytechnic Semarang, namely the question to Dr. Nekla. Yeah. Dental care professional are at high risk of the cross infection while treating patients. We talk about the gloves. It has two types of gloves. There are still sterile gloves and non-sterile gloves. The question is, how is your opinion about the non-sterile gloves that placed in open, but we sometimes still use to treat patient because of there is no sterile gloves? It is including cross-infection. If yes, what is the best alternative to solve it? Like this one, ma'am.
Okay, thank you very much for the questions. I believe we talk. The question is about the non-sterile gloves and the sterile gloves. Sterile gloves we usually use in the dental operating, yeah, in the operating area, meaning we need to really do the thorough infection control and wash our hand like before we wear the sterile gloves in the operating theater or the operating room to do some dental procedure under general anesthesia. Okay, so for the dental practice, we usually use the you know the gloves, the hand gloves that we usually use for like it can be non-powdered or powdered. It can be that there is some small, medium, or large. Okay, so since we don't put not really use the non the sterile gloves. We wear the gloves that we consider as sterile enough. Meaning, because when we use that gloves in the dental clinic, it comes from the box, the closed box, right? Yeah. So it's not recommended to put the box outside. Yeah. So we always put the hand gloves box inside the drawer or even in the cupboard in the dental clinic. Yeah, it's to prevent the the contamination from when we do some maybe we just use the burrs and etc. Okay, so basically, we use that only when we do it for the patients. Okay, but the rest of the remainings of the gloves inside the box has to be inside the cupboard or the drawer. All right, then only if we want to wear it, we want to use it, we have to remove our gloves that we wear that time, and then we dispose to the clinical waste bin. All right, then only we take a new gloves. Am I answering your question?
Yes, I think. What do you think about this answering, my friends? Is okay? Okay, sir. Though finally, we have reached in the end of the session. I would like to say thank you for the speakers or for the great seminar, and the audience for the active participation. Thank you for your attention, and I give the time to back to MC. Please.
Okay, Mr.
Thank you
Saliku.
very
Audience, we had already finished the first session. Thank you for the third speaker and the moderator. We would hand over certificate for the honorable speaker and moderator that will be displayed virtually. Please give a round of applause. Okay. Thank you, Dr. Nikla. Thank you, Mr. Saliku. Please take your seats. Well, ladies and gentlemen, now we come to the second session. We would like to welcome Dr. Gigi Raden Roro Pipit Okti Kusumastiwi MPH and Dr. Gigi Lani Sunarjo MDSC. And this presentation will be moderated by Dr. Bambang Sutomo SSIT MKes. Dr. Bambang Sutomo is a lecturer of Dental Health Department for Kemenkes Semarang.
Okay, thank you very much, as Mrs. Hermin, as Mr. Ceremony from the time that has been given to me. The Honorable Director Head Polytechnics, Poltekkes Kemenkes Semarang, Mr. Jeffrey Ardianto, MAPP Science. The Honorable Chairman Dental Head Department, Prof. Dr. Dentist Dia Fatmasari, Magister Dental Science. The Honorable to Chairman of the Committee One Day Webinar, and all participants is my love and happy in this occasion. Thank you to the community chair for give us the opportunity to act as a moderator. Greeting to the ladies and gentlemen of the international webinar participant on international one-day webinar on oral health therapy by themes prevention and controlling infection post-pandemic COVID-19 from dental auxiliaries. All participants, as we know, this sterilization is a very important stage in dental health service. The sterilization to be done with the aim of prevention cross infection. Okay, for more detail, we will call a resource person to speaker, but we will carry out discussion or question directly at the end one speaker presentation. Ladies and gentlemen, I'll start the first section. All right, ladies and gentlemen, I call Rick away and introduce our speaker and this conference. Please share to this CV. This first recent person who is face resource will be future. She is young, energetic, scientific, and more motivation. Yeah. The CV is Dr. Dentist Pipit Okti Kusuma Stuti. Kusumasti. Yeah. Okay. Kusumastiwi. And the place is Westbrook. Yeah. Westbrook, sex is family, religion is Islam. He is a dentist. He is a lecturer. Yeah. And this was born same to me. Yeah. Westbrook. Yeah. In resource human in Westbrook is good idea. Okay, ladies and gentlemen, stop screen, stop CV. Yeah. Ladies and gentlemen, this occasion is Dr. Pipit is titling by material preventing and control cross-infection post-pandemic for dental auxiliaries. How are you, Dr. Pipit?
I'm fine, thank you, Dr. Bambang. Nice to meet you.
Okay, thank you, Doctor. This time I see you looks, treasure and style looks young. Pipit
Thank
name
you.
is same as little bit. She is a girl and very clever.
Thank you so much, Dr. Bambang.
Okay, yeah. I completely leave the time to Dr. Pipit to present the material. Please, ma'am, this time presentation 13 minutes. This time for you to presentation. I am sorry, this material your screen personal or committee screen?
I will share screen by myself, Dr.
Okay.
Bambang. Thank you so
Yeah.
much.
Okay, Mrs.
Okay, can I start now, Dr. Bambang?
Okay, please, Mrs. Pipit.
Thank you so much. Is my share screen visible, Dr. Bambang and everybody?
Okay, your screen is good in here.
Okay, thank you so much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, first, let me introduce myself. My name is Pipit Okti Kusumastiwi. I'm a lecturer in Faculty of Dentistry, Universitas Muhammadiyah, Yogyakarta. And I'm as a Director of Medical Services in UMY Dental Hospital. Today, I would like to present my paper entitled Preventing and Controlling of Cross-Infection for Post-Pandemic for Dental Auxiliaries. Ladies and gentlemen, as we know that infection prevention and control is very important in healthcare services. It is because infection prevention and control become the key point in healthcare-associated infection prevention. And until now, healthcare-associated infection is still a heavy work in Indonesian healthcare service, even in worldwide. The prevalence of healthcare-associated infection is still high, occurring in 7 until 10% of inpatient, and moreover, 1 out of 3 intensive care unit patient is diagnosed with healthcare-associated infection. This is the first reason why infection prevention and control is very important for healthcare services. And the second reason of the importance of infection prevention and control is accreditation. We know that now in Indonesia, not only hospital accreditation, but also clinic accreditation and private clinic accreditation. And for hospital accreditation, infection prevention and control accomplished in 2 standards: patient safety standard and infection prevention and control standard. 2 standards for infection prevention and control. So, ladies and gentlemen, if we talk about infection prevention and control, of course, we must to talk about infection patient safety too, because infection prevention and control is one of the 6 of patient safety goals. So before we talk about infection prevention and control, I would like to further explain about development of patient safety in the world. So, ladies and gentlemen, patient safety has become an interesting issue since publication of this book. This book is published by International of Medicine in 1999, entitled "To Err is Human." Making a mistake is part of human. Healthcare officer, including dentists, doctor, dental therapists, are human too. So healthcare services has a potential for medical error. Yes, maybe some of you think that this is so only just a logical premise, but this logical premise has been supported by a scientific evidence. The scientific publication revealing that the mortality caused by medical error in America is higher than mortality caused by traffic accident, caused by mountain climbing, and so on. So after publication of this book, many efforts to be made to increase patient safety and increase the quality of healthcare in healthcare providers services. But did the mortality decrease? Sadly, it's not decreased, ladies and gentlemen. Even reported that the mortality is increased. The mortality is increased from 1999 to 2000, increased from 90,000 to 2,000 to 100,000, and slightly decreased in 2008, and then slightly increased fourfold in 2030, and decreased again in 2016. But ladies and gentlemen, the increase of this mortality rate was not always because by the bad quality of healthcare services. It can be caused by many research conduct concerning patient safety since the publication of this book. Thus, the data has been all revealed. And then in 2016, a scientific paper was published revealing that medical error was the third leading cause of death in United States. And in response for this paper, another scientific work was published in 2017 entitled Your Healthcare Might Kill You, Medical Error. So, ladies and gentlemen, patient safety until now still has a heavy duty for public healthcare services, including infection prevention and control. So, what should we do? What can I do to implement infection prevention and control in dental practice? Ladies and gentlemen, infection prevention and control in dental services can be implemented in three approach. Infection prevention and control for dental auxiliaries, including sterilization and disinfection, infection prevention and control for dental staff, including PPA, personal protective equipment, and hand hygiene. And the third is for environment, infection prevention and control for environment, including airflow, room management, and donning doving room. So for this meeting, I will focus on the first approach. This is infection prevention and control for dental auxiliary. So this is the general instrument processing for all medical instruments, not only dental auxiliaries. We start from the first stage is pre-cleaning. After we use the dental instrument, we need to do pre-cleaning with detergent and enzymatic, and then the next stage is cleaning. And after cleaning, we need to divide it into two. The instrument need sterilization or the instrument need disinfection. And the disinfection group, we are divided in three level: high level disinfection, intermediate level disinfection, and low level disinfection. After sterilization and disinfection, the medical instrument can be stored and ready to be reused. Okay, this is the first stage of dental medical instrument processing, reprocessing. The first stage is pre-cleaning. Staff should be properly educated and trained regarding the cleaning procedure, physical and chemical nature of the instrument, nature of the disinfection, and so on. And in this stage, all the staff during the process should be used PPA, personal protective equipment. And we do impressing the equipment in the detergent or the disinfection solution pure cleaning, at least at approximate 10 minutes. Avoid to prolong or overnight soaking of the devices. And if we have a patient suffering an infectious systemic disease, maybe HIV, maybe COVID, and then so on, we can use the different immersion box based on the risk category. And this is the enzyme, or this is the solution that we use in our dental hospital, enzyme. And I will show you the video for disinfection and for clinic in our treatment room for semi-critical item. or semi-critical devices, we do disinfection in treatment room. Yes, first in running water, and then we put the instrument in immersion box, including something like this, and we need to waiting for approximate 10 minutes. This is the process in a treatment room, and I will show you too in the process of pre-cleaning in center sterilization and supply department. It is something like this. Sorry, can you see my video? This is our pre-cleaning process, and we need to we use timer, and we immersing the equipment. Okay. Okay. After the pre-cleaning, we do cleaning. Cleaning is removal or visible soil, organic and inorganic material from the surface and object. Cleaning by manual subscribing and rubbing with brushing or automated scrubber, and thoroughly wash with water under pressure or running water. Not permitted to use cleaner that are abrasive or contain steel fiber, because they cause stretch and nest of microorganisms and increase the risk of rust formation. After cleaning, we need to drying before packing. And I will show you the video of drying process in UMI Dental Hospital. But I'm sorry, in dental hospital, we use a traditional method. Maybe in some hospital else, use the drying machine maybe, but in UMI Dental Hospital, we use traditional method with towel, something like this. Okay, we next to the next stage. After cleaning, we need to separate, or we need to define it, the instrument. One group or the instrument needs sterilization, and one group the instrument need disinfection. So we classification the devices in 3 groups: critical devices, semi-critical devices, and non-critical devices. For critical devices, the definition of critical devices is medical or dental devices that is intended to enter a normally sterile environment, sterile tissue, or the vascular. So the risk of infection for critical devices is high. So we need to reprocessing procedure with sterilization with steam, plasma, and ethylene oxide. And for example, in dentistry, of course, for SEP, for extraction procedure, USS Keller and KA file. And the second group is semi-critical devices, instrument, semi-critical instrument. The definition of semi-critical instrument is devices that are intended to come in contact with the mucous membrane or non-intact skin. The risk of infection for semi-critical devices is high or moderate. So we need to high-level disinfection for reprocessing procedure. And example for dentistry is diagnostic state, because contact with mucous membrane, and operative dentistry instrument for restorative or something, the instrument for restoration. And the third is non-critical devices. Devices come in contact with intact skin. Risk of infection is low. Reprocessing procedure, we need to do intermediate or low level instrument. And example in dentistry is stethoscope for our dental chair. So, ladies and gentlemen, we need to, we go to the next slide. Okay, sterilization. Sterilization is a process of complete elimination of or destruction of all form of microbial life, including both vegetative and spore form. And we can do sterilization by physical and chemical method. Next, I will show you the process of sterilization. I will show you from the cleaning room, we move to the packaging room, and we insert the instrument to the package, something like this, and we made labeling. I will explain to you the labeling in the next slide. The first labeling, and okay, yeah, this is the second labeling, and we press this package. Okay, yeah, something like this, and we move to the next room. Autoclave, this is sterilization room. We use autoclave.
5 minutes again, Mrs.
5 minutes, I guess. Okay. Yeah. And we close and we setting with the temperature and so on. Okay, next slide. Nah, after the instrument sterile, we take it from the autoclave and now we insert in the box, and we need to close the box, and the staff will take this instrument from the next room. Okay, this is the example autoclave, and this is the different method of sterilization with example. We have 3 methods: high temperature, low temperature, and liquid temperature. Maybe next 5 minutes, yeah, Dr. Bambang. Okay.
Okay.
This is disinfection. This is the method of disinfection. Disinfection is the process of complete elimination of vegetative room of microorganisms except the bacterial spore from inanimate object. So the differences between sterilization and disinfection is bacterial spore. Bacterial spore can be eliminated with sterilization. And we divided the level of disinfection in 3 levels: high level disinfection, intermediate level disinfection, and low level disinfection. High level disinfection is destroy all microorganisms except some bacterial spore. Intermediate level disinfection is the disinfection against Mycobacterium tuberculosis, and low level disinfection is remove the vegetative form. This is the method of disinfection with example. High level disinfection, intermediate level disinfection, and low level disinfection. Yeah. Maybe it is important for us disinfectant for dental instrument, furniture or amalgam condenser or cement condenser. This is semi-critical item, and we will do the sterilization if contact with blood, and we do ethanol if there is no contact with blood. Handpiece, this is critical or semi-critical item. We sterilization with autoclave. Dental impression, we need to spray with sodium hypochlorite. This direct restoration with disinfection with povidone iodine. Gown, Google, and dental unit is not non-critical item. So for Google and dental unit, we need to wipe with alcohol. But gown, Google, and dental unit is maybe there have blood spill. So this is the recommendation for blood spill on the surface, maybe in gown, in dental unit, and so on. We need to do decontamination if the blood spill is less than 10 milliliter. We do with sodium hypochlorite 100, and for more than 10 milliliter, we need to sodium hypochlorite 1 and 10, and the organic matter should be cleaned with absorbent material, and final disinfection may be done using sodium hypochlorite solution with 100 dilution. And it is for endodontic 5. In some clinic, reamers, files, broads is single use, but in other clinic is not for single use. If there are not single use, we can insert file into a scoring sponge soaked in 0.2 chlorhexidine and clean the file using stored in sponge. Place the file in wire mesh basket and immerse in the enzymatic cleaning solution. This is followed by 10 minutes ultrasonic solution, ultrasonification in enzymatic cleaning solution, and rise in run tap water for 10 or 12 seconds. This is the how we do the cleaning and sterilizing high and low speed dental handpiece for restorative dentistry. Pure to stem sterilization, remove any burr from the chuck before removing the handpiece from the coupling of the dental chair. Cleaning the outside of the handpiece, taking care to wipe down all clinical surface contact surface, lubricate the handpiece with oil from the pressure pack for the recommended period, check the debris, and check clean off any excess oil, sterilization in steam water, and steam sterilization, and use autoclave. And I will show you the cleaning of high and low speed, but I'm sorry, it's very minimal, not so complete like I explained before. Something like this. With,
2 minutes again.
Okay, almost done, Dr. Bambam. I'm sorry. we spray it with oil, with lubricant. Yeah. Okay. Next. Recognizing common mistake in the sterilizing room. Correct the sterilization of item. The divided item into three, semi-critical, critical, and non-critical is the important things for the reprocessing instrument. The second item is checking the efficiency of the instrument cleaning process. Lightning, it very important to check the cleaning of the instrument. And water quality, we need to periodic check acid treatment for heating element to remove deposit of the calcium, magnesium, aluminum, and other compound. This is the labeling that I show you in the video before. Storage package and storage room. Minimize the chance of damage to package during their storage. Package should be stored near sterilizing room sinks to prevent. This is we need to make a labeling for FIFO, first in, first out. This is the date of the sterilization. We sterilization in November maybe, and if the package is not broken, we can use this instrument until February. And I will show you the different color between two label. The color is pink if not sterile, before sterile, and after sterile, it can be changed to dark form. Okay, I think it's enough for me. Thank you so much, ladies and gentlemen, and thank you so much, Dr. Bambang. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Pipit. Applause, Dr. Pipit. Your presentation is excellent. Your innovation presentation by video. Okay, ladies and gentlemen, if you clear this material from Dr. Pipit, please you ask question. If you ask question, please you by raise hand or you write this chat room. Okay, Dr. Pipit, and this audience is to audience ask question to you. First question from Mr. Yunan Herianto from JKG Bandung. My one question for Dr. Pipit. If we don't have some water for washing hand, when we will take a patient, so is there war to handle that case? May we using some other to replace water? Please, Dr. Pipit, this time clarification this as question from Mr. Yunan.
Sorry, Dr. Bambang. Can you read this question again?
Yeah. If this condition is some water for washing hands, when we will take a patient, so is they won't handle that case. May we using some other to replace water? In this condition is done some water. This activity, this condition to patient or replace water on alternative method othernya.
Water for wash the instrument.
The washing hand. Yeah.
Oh, yeah.
Yeah.
For hand hygiene, I think, yeah.
Yes, cleaning and the washing to hand.
Okay, thank you so much, Dr. Bambang and all participant. Before we reprocessing the instrument, of course, we need to hand wash before cleaning and so on. And we need to uh, do the hand hygiene and cleaning in running water. And after we do the reprocessing instrument, and we will to the treatment, of course we need to hand hygiene again. And we need to wearing a glove. Maybe it's the answer from me, Dr. Bambang.
Okay, Dr. Pipit, your clarification is clear and makes understand participant from Mr. Yonan. Yeah. Okay, second question, Dr. Pipit. This question is from student Dental Heads Semarang. His name is Mairina Widianti. Yeah. How the definition is sterilization standard, yeah, and differential process, sterilizator and autoclave. Yeah. Please, your clarification.
Okay, thank you so much. This is the what is the differences between autoclave and sterilization. We know that the sterilization is the process to eliminate all the microorganism, including bacterial spore, including fungi, and so on. And for to do the sterilization, we have three methods. And the autoclave is one of the method for sterilization. Yeah. Maybe it's answer for me, Dr. Bambang.
Okay, this you ask this question is clearly and makes understand. Yeah. Okay, ladies and gentlemen, and this occasion is limited time. I am sorry in this year. Yeah. Thank you, Dr. Pipit, for you deliver in material. Yeah. This material is increased to as audience motivation in procedure sterilization. To all participants, if you the material, yeah, is I hope this material you dental health service in this day. Yeah. Conclusion this section, the scope infection and prevention control, dental auxiliaries, staffing and environments. Instrument process is pre-cleaning. This cleaning is sterilization and disinfection. Sterilization process is a complete elimination or destruction of all form of microbial life, includes but vegetative and spore form. By methods, high temperature, low temperature, and liquid chemical. Disinfection is process of completed elimination of vegetative form of microorganism except then bacterial spora from inanimate object. Okay, this consistent of high level disinfection, intermediate, low, intermediate, Okay, ladies and gentlemen, this occasion first speaker in this ends this time to Mrs. Hermin as Master of Ceremony.
Thank you, Dr. Pipit, for the very precious presentation. Please remain on the screen. We will hand over the certificate to the honorable speaker. Please give applause to the speaker at this event. Thank you very much. Kindly return to your agenda today, virtually. Thank you, Dr. Pipit. And Dr. Bambang Sutomo, please take your time to the next speaker.
Okay, thank you, Mrs. Hermin. To all participants, we have just listened to the presentation of material from Dr. Pipit. Then we will welcome the second presenter. The subject of material is preventing and control of cross-infection. So in the second material, we will discuss safety precautions and implementation infection. Who will deliver this second material? Please, Mr. Lani, come here. She is a lecturer, expert in the field of sterilization. She is a dentist and practitioner in the field of dental and oral health. Dr. Dentist Lani Sunarjo, Magister Dental Science. Yeah. Yeah, this CV is Mrs. Lani Sunarjo. Yeah. She is a lecturer in dental health program, and this time she is a chairman postgraduate program dental health Polytechnic Semarang. Yeah. Educational background, she is a Bachelor of Dentistry, Trisakti University of Jakarta, Master of Dental Science in the University of Melbourne, Australia, and doctoral program is Doctor of Medicine Science Diponegoro University. She is a publication as more publication. Yeah, next. Yeah, this publication is international and local. Yeah. Okay, stop screen. Yes, Mrs. Lani Sunarjo. Hello, Mrs. How are you?
Hello, Dr. Bambang. I'm fine, thanks.
Okay. Ma'am, in this occasion is looks careful and excited this morning. Yeah. In this section, this Lani will deliver material with title Safe Precautions and Implementation Infection Control Guideline in Dental School. Yeah. I give all my time to Dr. Lani. This time presentation, please you 13 minutes. Please you share my material to all audience.
Okay, thank you, Dr. Manda. Hi, how are you, everyone? Fine. Okay, hopefully that all of you in a good condition. Distinguished my director and vice director and all of staff, Politeknik Kesehatan Semarang, and the head of profession, PT GMI Center of Java, and our head of department, dental department. And also all participants on-site or daring. Okay. Today I would please share my material. Today I would like to talk about safety precaution and implementing infection control guideline in dental schools. Yeah. We know that there are many problems of clinic room in dental schools. The second one. Yeah. Next. Yeah. Okay, next. Okay, we know that problem of clinic rooms in dental schools, there are insufficient air ventilation and limited space and movement, limited upgrading sterilization equipment. Yes, there is some difficult for us to upgrade our sterilization equipment because we usually have equipment from Ministry of Health. So we wait for the new sterilization equipment. And there are dirty and clean areas mixed sometimes like this. And restrict area, how to stay safe? Yeah, it is our question, how to stay safe. And whether the infection control method used is appropriate or efficient. Nah, this is our question. So I would like to discuss with you. It is the sometimes the problem for the clinic room in dental school. But we try to do the best in our school. I'll tell you later. Okay? You may look at my presentation. Next. Next. Yeah, okay. I have already done this. Next. Next. Yeah. So we no no before. Yes, okay. Now we can know before. Yeah. Before. Figure one before. Yeah. No before. Yes. Stop. No, one more after this. Okay, stop. Yeah, okay. So we can look at the potential transmission of infection by which may spray in dental clinic. Yeah. So maybe from the index case with infection, they can direct contact through aerosol airborne organism to the subsequent patient, to the next patient. Or they may be have infectious to the instrument. Yeah, if we have improper sterilization, yeah, this is make damage. Yeah, make damage, and maybe the potential transmission of infection can happen. Okay, and maybe indirect for the contaminate instrument go to the staff, and staff have infected staff and go to substance patient. And it is our question, what pathogens that can be transmitted via aerosol? Yeah, next. That the researchers say, yeah, it can be transmitted by aerosol. Yeah, we can look at the Bayesian modeling estimated potential sources operator expure. Yeah, so and we look at figure 2A. We say that the greatest percentage around median 80.50% of the expure was not traceable to any of the collected samples. Ambient air microbiota computed the second largest percentage. So the ambient air, so yes, it look like bioaerosol. The second larger percentage, yeah, median around 10.5%, and the patient fluids contributed the the retaining exposure also median around 8.7%. So it was interesting to note that the microbiota and its operators' personal sample could be traced almost equally to their own patient salivary. Yeah, so it is the most important. So on patient salivary and nasal. And corridor microbiota was traceable more the nasal than to the salivary microbiota. So from the nasal is more greater than for the salivary. Okay, next. Okay, so when you look this figure 3, we can say that the escape of bioaerosol from the patients are two adjacent apparatus were examined. Yeah. Bioaerosol in operation adjacent to the patients are also demonstrated microbiota from patient fluids. Yeah. The median contribution of patient fluid to this bioaerosol around 8.5 for ultrasonic procedure. Yeah. Next. This is I would like to tell how to prevent or of disease transmission. We know that there are many sources, immediate sources, human sources, also instrument sources, and can be infected for the someone or for the instrument. Okay, next. Yeah. So we think about how to keep it safe and under control. Yeah. I think that we should apply standard precaution, including hand hygiene, use of personal protective equipment, respiratory hygiene, sharp safety, safe injection practices, sterile instrument and devices, clean and disinfected environment surfaces. Yeah, so you must apply this standard precaution. Okay. And the second one, comply with protocol or standard operational procedure of infection control that has been established. Yeah. And the last one, apply infection control continuously. That is set of policies and procedure aimed to prevent or stop spread of infection in oral care settings. Okay. After this, I would like to play video. This is video. It is from our department. I just want to show the example. Okay, please play the video. Yeah. Yeah, this video is it just look like those practices are designed to prevent the numerous routes of diseases transmission from an infectious source to a susceptible host through proper sterilization and disinfection. Okay, so it is the staff from the laboratorium. She talks about various of sterilization method in our school, our department. When you look at this, we have stove. Yeah, it is for the boiling method, and we also have boiling disinfector. And we have dry heat sterilization. And also we have infrared sterilization and also autoclave. We have conventional and modern autoclave. In here, I just want to analyze what is our infection control is properly or not, or it is efficient or not. Yeah, we tell this problem later. So this is we use a conventional boiling method. We use stove. Yeah, we use stove, and this is our dry heat sterilization. Yeah, and this is our infrared sterilization. Yeah, good. This is our autoclave. Yeah, for the steam under pressure sterilization. This also same, but the another equipment. Yeah. This is our boiling the this is our new autoclave. Yeah, this is new. Okay. And this is our boiling disinfector. Yeah, besides we use stove, we also use boiling disinfector. And we have two kinds of dry heat, the big one and the little one. Yeah, this is the wastafel when we clean the instrument, and also we wash our hand before we treat this instrument. This is the filling cabinet. We shift our instrument in this cabinet. Yeah, this there are many parts of this. Yeah, we decided into some racks. Yeah, this is for the instrument. This is for the plastic. We divided into instrument from plastic and from metal. Yeah, and the other side, before this, the other side, we have look like the doors or something of our windows. Windows open, and when we give the sterilized instrument from this, go to the clinic. Okay, I think it's enough the video. Thanks so much. Okay, stop it. Thanks so much. So like I said before, so these practices are designed to prevent the numerous routes of diseases transmission from an infectious source to a susceptible house through proper sterilization and disinfection. Okay, next. So when we look at the research say that efficacy of hand hygiene preparation in reduction of bacteria. So it's good, However, we use just plain soap, it's good, When we use antimicrobial soap, it's better. And the best is we use alcohol-based hand rub, Sometimes disadvantage of alcohol-based hand rub it make our hand is dry, Maybe you choose when you use the plain antimicrobial soap or alcohol-based hand rub. Maybe you don't use it every time, so make your hand dry. Okay, next. This is our instrument, boiling disinfector. I look at one researcher. What is the researcher recommend? We know that boiling disinfector procedure is boiled in boiling water for 15 minutes. The researcher said that the advantage is low cost. Yes, that's right. Accepted standard for high-level disinfection. I think it's the good one, the good invitation that accepted standard for high-level disinfection is good. It's good. An effective method for reprocessing reusable devices is good, but it have disadvantage. For example, inadequate germicidal effect. Especially for spore is difficult. When we use boiling method, it's difficult to eradicate the spore, and can be used for liquid material, cloth, and cotton, and sometimes cause rust on tools made of metal. Okay, this is for boiling. Next. This is for the dry heat sterilization. I look at the opinion from the two researchers. They said that we know that procedure heat 170 Celsius of 60 minutes or 160 degree Celsius for 120. This is look at the advantage. This is less complexity. No pressure required and vessels. It's good. It's good. And lighter in weight. Some is lighter compared to me. And be used for liquid material, clothes, and cotton. And sometimes doesn't cause rust on tools made of metal. But there's a disadvantage. A longer period of time, hence, for 60 minutes and 120 minutes. It's a long time. It's quite time. Yeah. And sometimes high temperature might limit some joints in sterilized tools. Okay, next. And our school have two kinds of autoclave. There is a conventional, the above instrument, and the like modern. Yeah, for the above we use stove. Yeah, for this, and for the under it is used electricity. Yeah, a researcher said that, yeah, we know that the procedure steam 120 degrees Celsius under pressure 1 atm for 12 and 15 minutes. And the advantage, we know that autoclave or steep under sterilization microorganisms can be eradicated almost 100 sterile. Yeah, so yeah, we recommend that we use it. Yeah, yeah, can be used for metal, cloth, glass, and rubber tools and minimal equipment damage. Yeah, but yeah, it has disadvantage. Yeah, it's quite expensive price. Sometimes water vapor remain on the wrapper. Yeah, this is sometimes look like wet. Yeah, look like white, yeah, wet. Yeah, and not be used to sterilize oil or powder material. Okay, next. This is a infrared sterilization. We use this in our school. Yeah. One researcher say about the advantage and disadvantage. Okay. For the procedure, we know that ozone disinfection in upper layer. So for the upper layer, we use ozone. Yeah. And the lower sterilization by infrared. Yeah. So by infrared lamp, high temperature in lower layer for 20 minutes. Yeah. How about the advantage? Yeah, low cost, kills almost 100% of bacteria, virus, germs, used for rapid sterilization. Yeah, but they have disadvantage. Yeah, sometimes yeah have disadvantage is okay. Inadequate chemical effect. However, decreasing amount of pathogen bacteria, there was a proliferation of bacteria in a part of some sterilized stools. Okay, next. And we use air purifier also in our dental clinic. Yeah, we know that one researcher said that the present study deals with an evaluation of the air purifier's effectiveness in reducing the concentration and different size of particulate matter and ions the real world indoor environment. So air purifier is effective to purified indoor environments. Yeah. Okay, next. Yeah, for the dental surrounding environment, we use also for dental chair, we use soap solution, dry and wet clothes. Others, combination of alcohol, 70%, and chlorine, 0.5%. The results showed that there was an effectiveness combination of chlorine 0.5% and alcohol 70% to decrease germ colony. Yeah. And the effectiveness of alcohol 70% to decrease germ colony, it is not significant, yeah, compared to when you combine alcohol with chlorine. Yeah, just alcohol is not significant to kill germ. Okay, next, I think it's the last. Okay, that's fine.
5
Yeah.
minutes again.
Yeah, okay, it's the last. Conclusion. Now we go to the conclusion when we analyze the infection control in our school is effective or not. Yeah. Infection control done in the dental school was appropriate and effective. However, absent of strict regulatory requirements and lack of appropriate instruction and lack of supervision, improper packaging and loading, faulty equipment and inadequate maintenance of equipment were considered as a main factors related to sterilization failures. Yeah, so it's the most important. Yeah, and the second one, considering the advantage and disadvantage of each method in infection control, the health worker should comply. Yeah, so as compliance is more, it is the most important thing. Yeah, comply a personal protective equipment workflow use in medical areas. So the work worker must use a personal protective equipment. Ya, itu ya, like mask, eyewear, and so on, and gloves or something. Yeah. Next. The next, yeah, it is our reference. Yeah, we have tens. And next. Thank you. Okay,
Okay.
thank you.
Yeah. Your presentation is a good idea. Yeah. Appreciate from me. Your material presentation is sterilization autoclave unit is new.
Yeah.
Yeah, very increase knowledge to all audience knowledge about processing sterilization. Okay, ladies and gentlemen, please you ask a question to the speaker, Dr. Lani. Please you ask question by raise hand, or you ask question by write in this chat room. Okay, this question is participant or student dental heads department. Yes, from Ananda Febri. Yeah. She is a student dental heads department, head Polytechnic of Semarang, Mrs. Yeah. This condition in real life, student option ignore infection control when practicing in clinics. What's a step do you take as a lecturer to overcome this problem? Please, Dr. Lani, clarification this question.
Okay, that's fine. Hello, Febri. How are you? Okay. I think it is sometimes is a difficult question to answer because it depend on your compliance. Yeah. Dental schools has regulatory how to have infection control. But if the easy way is do your hand washing, hand hygiene properly. Yeah, this is the most important thing. Do your hand washing, hand hygiene properly.
Novia Saputri from CKG Poltekkes Palembang. Oh, mau langsung. Oke, please Mrs. Intan Novia Saputri, please you question directly to Mrs. Lani. Please, Mrs. Hello, Mrs. Intan Novia Saputri.
Yeah, hello.
Hello, good afternoon. Please you directly question to Dr. Lani.
Okay, good afternoon, Dr. Lani. My name is Indonovia Saputri. I'm came from JKG Poltekkes Kemenkes Palembang. I have one question for you, Dr. Lani. May I give my question?
Yes, of
Okay,
course.
in our dental school, we use a large number of tools. For example, is in the number of basic instrument used. Then, which sterilization method is more efficient to use in dental schools in preventing cross-infection, Dr. Lani? Maybe that's my question, Doctor. Thank
Okay,
you.
that's fine. Thanks, Intan. I think the most good one is use autoclave. Yeah, steam under pressure. It is the good one. Nearly 100% eradicate the germ. Okay. This is okay, Intan?
Oh, Mrs. Intan, clearing this your question.
Yes, doctor, that's clear. Thank you.
Okay, thank you.
Okay, ladies and gentlemen, I am sorry this condition is limited times.
Okay,
Yes,
that's fine.
I am conclusion in this occasion. Yes, this conclusion this occasion material by Mrs. Lani. This conclusion. Yes. Conclusion this section is a problem of clinic room in dental school. Yeah. Consists of many aspects such as insufficient air ventilation, limited space on and movement, limited upgrading sterilization equipment, dirty and clean area mix, restricts how to stay safe. Whether the infection control method used is appropriate efficient. They keep it safe and under control by apply standard precaution, comply with protocol on standard operational procedure, and apply infection control continuously. Thank you, Dr. Lani. Don't you deliver material to all participants?
Yeah. Okay, that's fine.
Okay, Dr. Lani. I hope the material in this section can be benefit to
Okay,
all
that's fine.
participants,
Yeah,
Doctor.
yeah.
Thank you, Dr. Lani. Your
I'm sorry.
presentation.
Okay.
Yes,
That's
okay.
fine. May I have share something
Okay.
for the last?
Yes.
Okay, that's fine. Okay. Usually our colleague give you poetry, but I give you a song. That's fine? Okay, that's fine. This meeting today is very memorable. Next meeting is eagerly awaited. We would like to thank for the speakers. Hello, speakers, thank you. And the committee also, thank you, committee. Be healthy and successful for us. Okay, thank you so much.
Okay, thank you, Dr. Lani. You singer as the best. Your profession as lecturer and singer, Doctor.
Yes. Sambilannya penyanyi.
Thank you, Dr. Lani. Your presentation is excellent, and your material to make inspiration our participants with important application standard procedure in sterilization. Actually, I want to spend long time with a presenter and the entire audience, but limited time this section, we will immediately end the webinar in the second part. Okay, ladies and gentlemen, and this time I return to Miss Hermin Nugraheni. Thank you, as Mrs. Hermin, as Master Ceremony. Wabillahi taufiq walhidayah. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Lani Sunarjo and Dr. Bambang Sutomo. We will hand over a certificate that will be displayed virtually. Thank you for your time and enjoy the next agenda. Please give applause to the second session at this event. Ladies and gentlemen, we have come to the end of this enlightening and informative seminar. I hope you all have enjoyed and benefited from this presentation and discussion of our distinguished speakers and guests. Let us end this event with saying Hamdalah. Alhamdulillah. I would like to thank them once again for their valuable contributions and for making this seminar a success. I would also like to thank our sponsors, organizers, volunteers, media partners, and all of you for your participation and support. Please give a big round of applause to everyone who has made this possible. Billahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. See you next.